चेयर पर्सन फिर
लाइव चला गया, लाइव क्यों?
अभी नहीं। हाँ, डॉक्टर नितेश, डॉक्टर श्याम अग्रवाल, डॉक्टर मनीष। ठीक है, थैंक यू।
मैं भेजता हूँ।
हॉल इज लाइव नाउ।
तो ऐसे मत बोलो, घुमा रहे थे, घुमा कोई को जान के सुनना तो मैं गलत चीज बताएगा, जो उसको पता था उसने बताया। हर आदमी सीखता रहता है ये चीजें। अब मैंने ये बताया, हो सकता है किसी में फायदा हो जाए, ये करके अब वैसे चल इसको तो एक बार जैसे सीवी का ये वाला ये वाला खत्म हो गया, आपने स्टॉप शेयर कर दिया। कितनी देर में आप यहाँ पे डॉक्टर आएगी वो अपना बोलना शुरू कर दिया उसने, मॉडरेटर कितनी देर में, क्योंकि आपका काम है खत्म हो गया।
Hi, this is Dr. Farid. Anybody there?
Yes, sir.
This is hall A, na?
Yes, sir. Yes, sir.
Okay. ठीक है, ठीक है. Last है. I think I've been given.
Camera is also now.
Yeah.
Yes.
So is this background okay, or you want me to have the virtual?
Your background.
It's like
What is the background, sir?
it's actually a curtain. It's a real background,
Yeah.
some curtain.
Curtain is visible. Yes.
Yeah, it's
You are on a
okay.
chair and
Yeah.
on the background
Is
is
it
a
okay? Is it anything better could be done? What is it?
Let me check. Let me see. Yeah. Light is perfect, sir.
Light is perfect. And then the background is okay.
Background is also fine.
Fine. So I just leave it like that. I mean, I can make another curtain like this with more folds if you think it's better.
It is fine like this also, sir. But अगर जो हमारा actual वाला है, वो नहीं हो पा रहा है आपके इस पे?
Virtual पे? You mean the virtual background? Can you help me to get that?
जी सर, हाँ जी सर.
Yeah. So how do I get that virtual background?
मैं बताता हूँ सर. ये पीछे नीचे आप देखिए, नीचे जो पूरा ये पैनल है, यहाँ पर स्टार्ट वीडियो, वेयर इट इज स्टार्ट वीडियो, उसके साथ में एक छोटा सा एरो है. स्मॉल एरो. स्टार्ट वीडियो के बिल्कुल
साथ में वर्चुअल बैकग्राउंड.
यस. चूज वर्चुअल बैकग्राउंड.
राइट.
बट उससे पहले आपका जो वर्चुअल बैकग्राउंड जो हमने भेजा था, यू हैव सेव्ड समवेयर ऑन योर कंप्यूटर. इज इट सेव्ड समवेयर?
आई एम नॉट श्योर.
हाँ, उसको सेव करना पड़ेगा सर कहीं पर, मे बी डेस्कटॉप और वेयर इट सूट्स यू. तो वो करना पड़ेगा पहले सर. Then only it will.
They are all in my, my phone. इसमें नहीं है, मेरे phone में नहीं है.
अच्छा. तो मैं आपको ईमेल करूं, उससे बेटर रहेगा आपके लिए.
हाँ, rangarao@gmail.com में.
rangarao
@gmail.com.
ठीक है, मैं अभी करता हूँ. ओके, जस्ट होल्ड ऑन सर. आया होगा आपके पास, प्लीज चेक फ्रॉम infovirtuecons@gmail.com से आया होगा आपके पास।
मैं भेजा आपने?
हाँ जी, हाँ जी।
कहाँ,
check.
कौन, किसके नाम से?
infovirtuecons से ना आएगा आपके पास।
पंकज कौशल।
हाँ जी, हाँ जी, पंकज कौशल। इसको आप सेव कर लीजिए सर, डेस्कटॉप पर या वगैरह पर।
वो इसलिए ना जब ये हाँ लाइफ पे
Is it saved, sir?
Yeah. Now I just get it. Virtual backgrounds and then maybe.
जी। अब आप now you have to go to choose virtual background. And यहाँ पर एक plus mark is there at the extreme right.
Yeah.
उसको क्लिक कीजिए, add image. जब आप इसको क्लिक करेंगे add image में,
It's coming like that. Are you able to see me? No.
have you selected any image, sir?
I have selected that.
Yes. We can see you, but it is not working properly. Yeah. Because of some laptop issue or something. Yeah. So it's better not to use.
This problem was also there yesterday as well. So I थोड़ा सा I think sir अगर थोड़ा सा स्क्रीन के पास आएंगे तो ये नहीं होगा problem.
Okay. So maybe I think I'll use mine if it is okay. My background, whatever it is now, is it okay?
Yes, it is fine now, sir.
Mine is fine. Okay. ठीक है, fine. ठीक है, चलो, thanks. I'll join you again.
Okay, sir.
Yeah, thank you. Yeah, Parneet, all under control. Lung session कौन कर रहे हैं? आप कर रहे हो क्या? Lung session who is doing?
मैं और डॉक्टर मृदुल हैं सर.
Okay, I think one of the radiation oncologists has dropped out. Shagun from Lucknow.
Sir, we have to start session in 4 minutes, sir. We are already live.
We already have others, so we can
Right. Okay. I'm leaving.
Okay.
Achha, another sir, Dr. Dargadosh is also not coming, so we have only one chair for session.
Hello, Paneet sir.
Hi Pooja, I'm there.
Hello, good evening, sir. Sir, we can start the session now.
Okay, we have the speakers and everybody.
Yes, sir, we have.
Just give me one.
Sure, sir.
Just give me 1 minute. I'll start. Hello everyone. Very warm welcome to everyone to the first Paras Cancer Conclave. It was a very stimulating session the previous day, and I hope everybody joined and availed the opportunity to listen to all the doings of oncology. Today we are starting the day 2 of the conference, and we start with the lung session. The lung session will be chaired by Dr. A.K. Anand. Good morning, good evening, sir. This is Dr. Praneeth, sir. Sir, welcome, sir. Dr. Anand is currently Senior Director Radiation Oncology at Max Hospital, Saket, and has many numerous international and national awards, and has numerous papers in Indian and international journals. I personally had the privilege of studying under sir and working under his guidance. Sir, welcome, sir, to the conference. Sir, please unmute yourself, sir. Hello, sir.
Okay. Thank you very much, Paneet, for inviting.
Thank you, sir. So please start the session, sir. You can by inviting the speaker, sir.
Yeah. So, good evening to all of you. And we are going to have a very interesting session on lung cancer. There will be 2 talks, 1 debate and 1 panel discussion. And the first talk is by Dr. Arvind Kumar. He is from Medanta now, from Gurugram, NCR, Delhi. And he's going to speak on what is new in lung cancer surgery. And as we all know that lung cancer surgery also is making rapid strides in its technology, in its technique of performing surgery, reducing the morbidity, and trying to improve the survival and its role in multimodality management of lung cancer. The surgeons are also now participating wholeheartedly. So I will now invite Dr. Arvind Kumar to present his talk on what is new in lung cancer surgery. Dr. Arvind Kumar, please.
Sir, just a small input, sir. Please, I'll request the speakers to stick to the time, sir. We have an inauguration at 7. We have to finish the session by 7 o'clock, sir. Thank you, sir.
Okay. Okay.
Good evening, friends. Thank you, Dr. Anand, for your very kind words. First and foremost, my sincere regards and thanks to organizers, Paras Cancer Center, particularly Dr. Rangarao, for this very kind opportunity. And good evening, all the delegates. Since the time is essence, let me just switch on the stop clock so that I stop sharp at 14 minutes. The title assigned to me is What's New in Surgery for Lung Cancer. So what has happened is that in the coming years, I suspect that application of low dose CT scan in more and more centers is probably going to lead to discovery of more and more cases of early lung cancer. I'm already seeing it in the COVID time where a lot of patients have had their CT scans done for COVID purposes. And during this period, nearly 6-7 patients I have operated where asymptomatic, very early stage lung cancer was picked up. So that benefit of CT scan screening, if I may use that word, this is not truly screening, but this was some kind of a screening because it was not done for lung cancer, that's there. So we are going to see probably, hopefully, more and more of early lung cancer. Recent advances in the surgical part have basically focused on 3 things, making it less and less traumatic, enhancing the recovery of patients after surgery, and trying to preserve the lung function so that we can offer this surgery to more and more so-called earlier unfit kind of patients. So sublobar resections instead of lobectomy is one area where work is going on. Use of minimally invasive lung resectional techniques, thoracoscopic surgery using a single port approach to decrease the trauma, less invasive techniques in anesthesia using non-intubated techniques, and of course the robotic applications in the present robot or the future forms which are there. These are the areas where this is working. Most of the current clinical guidelines recommend standard lobectomy as the treatment of choice for stage 1A non-small cell lung cancer. However, the application of sublobar resections has regained attention because of many patients who had suboptimal lung function. At present, sublobar resection is recommended for lesions less than 2 centimeters and for pure ground glass nodules which are there, and part solid nodules with this consolidation to tumor CT ratio less than 0.25. Important thing is that whether you do sublobar or you do a lobar resection, there is adequate surgical resection margin is the most important determinant of local recurrence. And the National Comprehensive Cancer NCCN network currently suggests a resection margin of 2 centimeter or greater, or a margin to tumor ratio 1 or greater. Although segmentectomy and wedge resections are grouped together as sublobar resections and analyzed with lobectomy, but there is a need to actually separate them, group them together, and they are oncologically different. Now, many times people feel, okay, it's a segmentectomy, this will be easier, but truly speaking, lobectomy is a far more easier operation to do than segmentectomy, which is technically more challenging, but it's better than wedge resection because it facilitates more comprehensive nodal staging with the removal of intralobar and hilar lymph nodes. Now, there are several large prospective trials which are ongoing to assess long-term outcome for patients who are fit to undergo lobectomy, but then several questions, whether it is inferior or not, what is the long-term survival outcome, and most important, is morbidity following sublobar resection really less than that following lobectomy? So these are questions where the clear-cut categorical yes or no answers are not yet available. Until then, segmentectomy can be safely advised only to small lesions less than 2 centimeters in borderline fitness patients. However, this recommendation may change in future. Now, VATS has come up in a big way. Initially, when it came, there was a doubt whether this will be oncologically inferior, whether it will meet the test of time, whether the lymph node yield will be same or more, whether the morbidity will be less, whether the survival will be less. But all these questions have been more than adequately answered in the recent past. I'm not going to read all the details, but suffices to say that all these questions have been answered, that this is oncologically equivalent, at least equivalent. And there are numerous reports where there are reports of better survival. Lymph node yield when VATS is done at standard centers has been reported to be as good as in open surgery. And this question, whether this is inferior or not, has been put to rest. Also, in the beginning, there was this issue of port site metastasis, which had gained a lot of attention. That issue also was because of the instruments being put through the bare wounds, which also now has been addressed. In the recent past, there are hardly any reports of this kind of thing. Now there are attempts at further reducing the trauma by reducing the number of ports. So from 4 ports, you go to 3 ports or 2 ports, or the uniportal, or even use of subxiphoid technique for VATS is now what is happening. Now, does uniportal really lead to less pain than the multiportal? That has been again area of intense debate. There are some reports which say that uniportal produces less pain, but there are many others where actually after a few days or few weeks, the pain scores have been shown to be equal. So this question, this discussion continues to be there. The last line, the subxiphoid uniportal, is a variant of uniportal, which is usually performed through single intercostal space with the theoretical benefits of reducing the intercostal neuralgia. Now, this was about the surgery part, but side by side, there are advancements occurring in the anesthesia as well. So thoracoscopic pulmonary dissections are conventionally performed under intubated general anesthesia with single lung ventilation achieved by the use of a double lumen endotracheal tube or an endobronchial blocker. Now this has effects because once you put the tube and tube is there, so intubation related trauma, residual neuromuscular paralysis, pulmonary atelectasis, ventilation induced lung injury, and post-op nausea, vomiting are issues. So starting with simple surgeries like pneumothorax, biopsy of pulmonary nodules, people started practicing what is called non-intubated anesthesia techniques by using intrathoracic intercostal nerve block, vagal block, and target controlled sedation. Now this allows anatomical resection with medial sinus lymph node dissection, etc., to be performed under spontaneous breathing without triggering cough reflexes, despite your handling the lung and doing hilar manipulation. So vagal block actually allows that. Several pioneers of this non-intubated uniportal VATS also proved the feasibility and safety of this approach for anatomical pulmonary dissections for selected patients. And more recently, a new modification of this technique called tubeless thoracoscopic surgery, in which the patient is completely free of endotracheal tube intubation, and they don't even put a post-operative chest tube in these patients, has been developed as a fast-track thoracic surgical procedure. But I must say that this is report from a single center, and therefore widespread application of this will actually need this to be tested in a bigger group. And finally, robotic surgery has been for lung cancer, has been there now for almost 2 decades. Everybody knows the benefits, the 3D vision, the better depth perception, the endo-wristed instruments with 7 degrees of freedom of movement, giving us absolutely almost hand-like precision in handling the vessels, and particularly when you have a difficult kind of hilum and you have to do a lot of dissection, or there are some difficulties in dissecting and isolating the vessels, then this endo-wrist technique, where you can actually move the instrument like an endo-wrist at the site of dissection, comes in handy. Anyone who has handled a robot will know how much benefit comes from this endo-wristed instruments. And this allows for incorporation of more lung cancer cases to be operated. So if I was to do a case by VATS versus I was to do the same case by robotic, I think, and there is a difficult dissection, there are some lymph nodes stuck to vessels, all that dissection can be done better with robotic assistance. And by chance, if there is some bleeding, etc., and you need to do some intracorporeal suturing, even that becomes much easier with robot than with thoracoscopic techniques. It has a shorter learning curve. Everybody has proved that the lymph node yield is better. When it comes to pain and hospital stay, the series which have compared VATS with robot head-to-head have not reported any less pain, because the ports remain the same, the technique remains the same. Only thing is the ease of doing procedure is better. And all those who have done both, and I have done both, they feel that the dissection is much better in the robotic method. But whether that much better, so-called much better dissection actually translates into a better patient survival in terms of better post-operative outcome, shorter hospital stay, less pain, less morbidity, that is not yet proved beyond doubt. And of course, there is a huge disadvantage of the cost. There is also the disadvantage of lack of haptic feedback. We've been hearing for almost a decade that they are now coming up with the systems which will have haptic feedback, but till now this has not occurred. Even incorporation of the staplers into the robotic system has occurred, but it has not really been as nice as one would have expected. Incorporation of energy sources definitely has happened. So staplers continue to be used separately because it's expensive also, and it's not the same finesse as using other instruments. So in terms of superiority of the robotic method over VATS, the final outcome is yet to come because long-term data is not there. So to summarize, with advances in diagnostic modalities, coming years are going to see more and more of early lung cancer. Number one. Number two, as of today, now with Dr. Anand chairing the session, I would really make this statement very, very cautiously and carefully. As of today, surgery continues to be the single most effective treatment option for early stage lung cancer. Refinements in techniques have allowed for even complex lung preserving surgeries like sleeve and double sleeve to be performed by minimally invasive surgeries. Now, earlier when we started, involvement of the carina where sleeve resection is to be done, or involvement of the vessels where a vascular sleeve is to be done, was an absolute contraindication. But now there are empty number of reports where a single sleeve or double sleeve has been performed by VATS, even by uniportal technique. So emphasis is now shifting to doing it more and more by VATS, and it's shifting to doing lung preservation as far as possible. Now, newer techniques have gone a long way in improving the quality of life in patients with lung cancer. And as we continue to make advances in the VATS techniques, in the anesthesia techniques, I'm sure we will be able to reduce the pain and trauma of the surgery and make the outcome of these patients better and better. Ladies and gentlemen, thank you very much for your time and your attention. Dr. Anand, thank you very much for allowing me to give this presentation. And thanks to Paras Cancer Center once again. Dr. Rangarao, thank you very much once again. Sir, I finished in time. In fact, 2 minutes before time.
Thank you, sir. Thank you very much, sir.
And you get 10 out of 10 finishing in time, and everybody down the line has to follow his example. And so coming to the topic, it's a very, very, I would say, interesting topic when we sit with surgeons, the radiation oncologists, and that is the best forum to discuss this kind of this thing. So I would now like to ask if there is any question from the audience. Is there anybody who has raised any question?
So we can have questions at the end of the session, sir.
Okay, so Dr. Arvind, this your statement whether the surgery is the gold standard we are debating now. Next coming up, the two debaters are Dr. Shubham Garg. He will be for the motion that early operable cancer, lung cancer, surgery is the gold standard. And Dr. Anil Tibdewal from Mumbai, he will speak against it. And let's hear what points they make, and then we'll reach it to some conclusion till we have another conference on this topic. So I would first invite Dr. Shubham Garg to speak for early operable lung cancer and surgery is the gold standard.
Thank you, sir. Thank you so much. Following Dr. Arvind Kumar, the task becomes actually easy because he has sold surgery so well that I don't need to actually prove it. I just need to tell what evidence exists in favor of surgery. But what, in continuation with what Dr. Arvind Kumar actually talked about, that we can look into why he just spoke about to make you understand why surgery is still a better option and how surgery is still improving day by day and how we can make life easier for our surgical patients. But the basic surgical technique that we have all been studied or we know is to do a standard lobectomy with a systematic lymph node dissection. This stays the gold standard for surgical management. Obviously, the sublobar resections are developing, and as the evidence gathers, there will be more and more uptake for that. But the three options, the open surgery, the VATS, and robotic, remain the bread and butter for thoracic oncosurgeons. Now, what has happened in the past, probably say 15 to 20 years, that SBRT or the stereotactic radiation has come up asking for equivalence to surgical outcome, and the claimants say that that it's a non-invasive technique. Obviously, whenever you do a surgery, you are going to go inside the body, however little inside you are, but still you are going to go inside. It's going to be a non-traumatic SBRT. It's going to be painless, and it's going to be a bloodless surgery. But when we talk about SBRT, we have to look into the fact that what we are getting into when we offer a patient SBRT. Now, once we offer patient a non-invasive, bloodless, non-traumatic procedure, we also offer them that we will not be able to give them a pathological nodal evaluation at the end of their treatment. Having said that, we all select our patients so well that the patient should have a mediastinal negative staging with the EBUS, but still we know what is the false negative values for any EBUS procedure done at any center is. So SBRT does not allow you to do that. Having said that, it also forfeits the possibility of giving adjuvant chemotherapy because you don't know the nodal staging, and if the mediastinal staging was found to be negative to begin with, falsely negative, the patient would actually get undertreated if we are not able to give them the adjuvant chemotherapy which they require. Once you complete the treatment, there are certain uncertainties in the radiographic follow-up because the scar that is left behind many times mimic the malignancy itself. There might be minimal uptake even if you follow it up with a PET scan. It leads to a number of possible interventions taking place. You need to keep the patient on tenterhooks that, this might not be disease. Will follow you up after, suppose, say 3 months with a repeat imaging. And God forbid, if a disease comes back, there is actually increased operative risk of post SBRT salvage surgery. Whereas the surgery, it gives us complete nodal evaluation. It's almost like a staging procedure. You go in, you take the lobe out, you do a systemic mediastinal staging. It gives you better staging, and obviously there is better decision making for adjuvant treatment. Now, we all know that as surgeons, what happens is that patients actually which fail, they fail distantly and not locally, which proves that in spite of doing a good radical treatment, the chances of disease failing distally are higher, and where the evidence lies is that it might be the nodal staging which actually leads to the disease coming back. So with SBRT, you are never going to provide nodal clearance as good as surgery. There is a better defined follow-up following surgery because there is no suspense in the radiography. If there is a lesion which comes up later, it might be a malignancy, and you follow up that way. So once you look at SBRT versus surgery, you don't find a randomized evidence for either better or equitable disease-free survival or OS. And please pay attention to the word randomized, because I know the claimants, and as Anil would talk about the great evidence which exists in form of the RTOG 0236 and 0618, with the new 5-year data also coming out for 0618, we know that there is an option which for SBRT which exists, but the studies which were started accruing for a randomized trial included the STARS, the ROSEL, and the RTOG 1021 have not accrued patients in that number, and they had to be prematurely closed. What we are left with are possible new studies which are actually accruing patients, namely the RTOG 3502, the stablemates, the Sabertooth, and the Valor study, which might probably give us an answer, hopefully, in terms of what is the best possible solution is. But a new term has creeped up into our practice, which is specialty bias, and it has not been seen anywhere as much as it has been seen in surgery, where SBRT, where you feel that your oncology colleagues might be actually not telling the true story, and it stays for both sides of the table. So what is the specialty bias? That you feel that the surgeon does not offer the patient a non-surgical option which has equivalent result, whereas the surgeon feels that the radiation oncologist, if they interact with the patient, do not offer them surgery and take the decision themselves that he is not operable. That is why they have gone to the extent that in the Sabertooth trial, they have put the onus on explaining to the patient for choosing a technique for treatment to the pulmonologist, and it's actually the nurse which gets the consent signed from the patient, and only then do they meet the radiation oncologist or the surgical oncologist. But we don't need to go back and to look into how we can avoid this specialty bias. The ASCO guidelines, although these are 2017, but they still hold good. They talk about, if you look at the first point, that the decision to undergo surgery should be made by the surgeon and the patient in collaboration with the family. And second point, SBRT is not recommended as an alternative to surgery outside of a clinical trial. Lobectomy with systematic mediastinal hilar lymph node evaluation remains the recommended treatment with strong recommendation and high quality of evidence. There is that recommendation 1C, which talks of a high operative risk for surgery, where the MDT should decide what is the best possible option. However, the high operative risk is actually to be defined by the surgeon itself. There is no universally accepted definition of a high operative risk, as it has been shown that different studies might quote different FE1 DLC values, but it is only
Shubham, your time is over.
Sir, I put my hands up. Thank you.
Thank you very much for clarifying a lot of points. And now let's see what Anil has to say about this, and then we will have a discussion along with Dr. Arvind Kumar. Also will involve him into this controversial topic. So now please, Dr. Anil, if they want to come over and debate against the motion.
Sure, sir. Thank you very much. Shubham has made my job a little bit easier. So I'll be, are you able to see my slide and able to hear me?
Yes, yes.
Yes, sir.
So I'll be speaking for SBRT and against surgery for early operable lung cancer. As Shubham has already told you about the advantages of the SBRT in terms of outpatient non-invasive.
Also, please make your slides full screen. It's not full screen.
It is full screen only.
Okay.
So it's a highly precise and highly conformal treatment technique, and it delivers very high doses per fraction. It usually delivers in 2 to 5 fraction, and there has been a steep dose gradient which allows the radiation oncologist to deposit the entire dose within the tumor and minimal dose to the normal tissue.
I think you have the wrong slide, sir. It is not open, sir.
I'm sorry. Now can you see my slide?
Please share the screen again, sir, once again.
Just hold on. Now can you able to are you able to see
Yes,
my
sir.
slide?
Yes, sir. Now we are able to
Yes,
see. Thank you, sir.
Okay, thank you. Sorry for that. So in many retrospective studies which consist of basically medically inoperable, but few of them are medically operable, you can see the 5-year overall survival, which is approximately 50% to 70%, especially from the Japanese data, and prospective studies also, which we will discuss in the next few slides, 5-year overall survival from 50 to 70%. Now, so this is the first the analysis from the Japanese group, which consists of 257 patients, and they have showed that 5-year overall survival is approximately 65% for medically operable. And they have also highlighted this point that the BED should be at least 100 gray if you want to have a better local control and better overall survival. In the Japanese group 0403, the 5-year overall survival was 54% in operable patient, and the 10-year overall survival is 24%. The median age of this group was 79 years. Another data from Japanese 5-year overall survival 72% and 62%. In the US also, from Timmerman et al., small pilot study RTOG 0618, 4-year overall survival 56%, median overall survival 55.2 months. So we have the evidence to say that SBRT could provide a comparable overall survival rate as compared to the surgery. However, as already mentioned by Shubham, there are 3 or 4 randomized control trials which were ongoing but terminated due to poor accrual. But Shubham has not said the reason of the poor accrual. The author in their reply has stated that the failure of thoracic surgeon to participate in this randomized control trial was the main reason for the poor accrual. And many of the centers in the US and the Dutch declined to join the study after it has been started accruing the patient. So the onus was on the our oncology community to generate the evidence. Evidence was there, but in a randomized control trial, no. So whatever the randomization happened, there was a pooled analysis from Chang et al., which was published in Lancet Oncology. However, it was very small sample size of 55 or 60 patients. The 3-year overall survival was actually numerically better in SABR versus surgery. The 3-year recurrence-free survival was also comparable. Also, the result from Roselle multicenter randomized control trial about the patient-reported outcome, the dyspnea and the pain score were less in SABR compared to surgery, as well as the global health-related quality of life and indirect cost were significantly favorable and cheaper with SABR as compared to surgical arm. Now, when you do not have a randomized control trial, the statistical method is the propensity score matching with the comparison for the confounding variable. There are multiple PSM analysis, and one of these analyses shows that well-matched SABR and lobectomy cohort demonstrated similar overall survival. Mind you, the 90-day mortality was highest for lobectomy, 4%, and the SABR 1.3%. So this is another PSM analysis which also shows that the loco-regional control was better in SABR and the overall survival were not significantly different. Now, the Zhang et al. has done a meta-analysis of all the PSM comparison studies. As usually expected, the surgery was associated with better overall survival, but there was no difference in cancer-specific survival, local control, the disease-free survival, and the distant control. And they have recommended that there should be a phase 3 randomized control trial. Now, is there any impact on quality of life with the SBRT, as many of our oncologists are very uncertain about the SBRT? There is no change in the quality of life, clinically or statistically significant difference. PFT, post-surgery and SBRT. I like the statement of Dr. Arvind that for lung preservation, emphasis should be on the lung and the preservation. And they have shown that the pulmonary function test was significantly diminished after surgery for all follow-up duration to the extent of 11 to 17%. But however, after SBRT, PFT remained stable for all the follow-up duration. Now, SBRT in elderly, we all know that as the age increases, the survival and the post-operative mortality also increases. So in the Amsterdam Cancer Registry, the 30-day mortality was 7.4% for surgery and 1% for SBRT. However, if you see the time trend analysis, the utilization rate of surgery has gone down and the utilization rate of SBRT has increased from 26 to 42%. And the overall survival has also increased only for the SBRT arm as the time has evolved from 2001 to 2007. Now coming to the post-op mortality of real-world data. The post-op mortality is 2.7 to 9.3% in the community practice. However, it was 0% in the stereotactic ablative radiotherapy arm. Post-op pain in surgery, we all know that approximately 5 to 10% of the patient will have a chest wall pain after the surgery, whether VATS or the anterolateral thoracotomy. So this is a randomized control trial which shows us that approximately 10% of the patient will have moderate to severe pain in both the group, VATS as well as anterolateral thoracotomy. SBRT use, even if we do not have the randomized control trial, the utilization rate of SBRT has gone up from 2004 to 2011. And what is the main reason behind it is the patient preference out of their own choice. Even if the surgeons or the pulmonologists are not recommending for that, the physician or the patient wanted to have the SBRT. So there are multiple ongoing studies, and I would like all the thoracic oncologists, especially surgeons, that you should encourage the patient to participate in the clinical trial. Otherwise, so whatever debate we do, we will not be able to end this debate of surgery versus SBRT, especially in operable early stage lung cancer. I like the statement from my friend Dr. Shubham that in saber-tooth, the onus was put on the pulmonologist to counsel the patient for SBRT versus surgery. So hopefully this 5 randomized control trial will give us an answer. So in my conclusion or summary slide, they have got a comparable loco-regional control rate. 5-year overall survival is also encouraging. There is a minimal toxicity with no change in quality of life, no immediate mortality risk, and it is suitable for all location, elderly, low PFT, severe COPD, all. So with this, I would like to thank the organizer for giving me this opportunity, and Dr. A.K. Anand and Dr. Shubham.
Thank you, Dr. Anil. And it's very good debate. And I would say that you presented your data very comprehensively. So now I will give an opportunity to Dr. Shubham if he has any points to counter in about maybe 2 minutes regarding the Anil's presentation. You want to say something?
Yes,
and
sir,
then we
just-
can have a discussion.
I'll just take a minute that, we can't use parameters like pain, like quality of life, like fall in PFT in relation with surgery, because these are the things that actually you can't do a surgery without. You can see the quantum of pain will always be more than SBRT, but what we are doing treatment is for better survival of the patients, which is still to be proved. I am sure that we all would, and believe me, a surgeon would never want to operate on a patient whose outcome is going to be bad. So the very reason the number of surgeries have gone down and probably the SBRT data is picking up is because the surgeons themselves are sending patients to the radiation oncologist that they feel that this patient might not do good. So I'm sure the randomized data will help us close this debate, but till then the debate is still on.
Sir, you are muted. Sir, please unmute yourself.
Is there any question from the house? Anybody wants to raise any point? So I would like to conclude this session and say that it is not easy. It is not easy to offer surgery or SBRT to a given patient. And from whatever data we are getting, probably for medically inoperable or medically challenged patient, multiple comorbidities, SBRT is the treatment of choice. So I think we have to find out which patient needs SBRT. In medically operable, there are two classes. One is that patient is against surgery. So if patient decides to not to do surgery, he is in his full right. And from the data, Anil has shown that at least it gives same survival, although we are not doing lymph node sampling, but we all know EBUS and mediastinoscopic lymph node biopsy can give us a good staging of lung cancer within the specificity of 90% or more. And we have seen that the patients are, not many patients are dying of distant metastasis, about 10 to 15% develop distant metastasis. So somewhere the data is there that SBRT is nearly equivalent to surgery. And this apprehension that without lymph node staging, we are under treating the patient is not holding good in whatever trials and studies which we have. However, in a medically fit patient, young patient, and if he is very keen to know about his stage, etc., surgery gives that edge. We all agree. So if Dr. Arvind has any comment before we go on to this. Dr. Arvind is there? So therefore, I think he's not here. And so anybody who wants to put a comment, how many people give chemotherapy after, sir? What is the data on adjuvant chemotherapy? Anil, you have any comment on adjuvant? Because they say that we don't offer chemotherapy to these patients.
Well, generally, the data regarding adjuvant chemotherapy after SBRT is not so great. However, there are NCDB analysis which suggests that if given adjuvant chemotherapy, especially in T size more than 4 centimeter, there has been an improvement in the local regional control as well as the distant control. However, there has been no level 2 or level 1 evidence in favor of the adjuvant chemotherapy. However, we also must acknowledge the fact that the T size, the radiological size as well as the pathological size has a very good high concordance index. So if the patient is not having a size of more than 4 centimeter, most probably he will not require adjuvant chemotherapy after SBRT.
Yeah. So data regarding adjuvant chemotherapy helping improve survival post SBRT is more or less not there. And therefore, the choice of using chemotherapy is very much left to the treating physician, depending upon the health of the patient, because many times we do this SBRT in medically challenged patients. So therefore, chemo will also be difficult. I just want to comment on Shubham's this thing that the quality of life. He says that quality of life. So you feel that quality of life should not be a parameter to see? I think we should. Even so, if surgery gives equivalent survival with worse quality of life, how can you argue?
So the quality of life, I meant that there will be an impairment in quality of life with the surgical technique as compared to if you're not offering any surgery. So there will be more pain, there will be a little impairment, but if that is within the limits, and that is why we have the medically operable section where you feel that you will be able to give them a good quality of life, and only those patients would you offer them surgery.
Dr. Arvind, he was here and then again he is. So Dr. Arvind, what do you feel? You said that newer surgical techniques can reduce pain and post whatever thoracotomy, neuralgia, intercostal pain, etc. is less with the latest techniques. What do you want to say about this?
So you're asking me to comment on VATS versus thoracotomy?
No, whatever overall surgery in stage 1 lung cancer, you perform some surgery. It may be VATS, it may be robotic. What about quality of life of these patients?
So quality of life, so there are 3 techniques. You have thoracotomy, you have VATS, which could be multiportal or uniportal, and it could be robotic assisted. So robotic assisted or robotic unassisted, the VATS, as far as quality of life is concerned, there is hardly any difference because the number of ports remain the same, the port trauma, etc., is the same. But when you compare VATS or robotic on one hand with thoracotomy on the other hand, there is a huge difference. And if anyone has any doubt, I would just request him to come and spend a day with me in the ward, and you see a thoracotomy patient and on one day after surgery, and you see a VATS patient one day after surgery. And I don't think we will need to talk to him about that. There is a huge difference. There is a significantly improved quality of life following this thing. One of the very important parameters, Dr. Anand, these days is return to work. A lot of people are having difficulty taking. Earlier, a decade back, we used to hear this argument from Western countries, but today it's become important in our country as well. How soon can I join my duty? And there is again a huge difference between thoracotomy and keyhole procedures as far as return to work is concerned.
Thank you, sir. Sir, we've exceeded time, sir. So can we go to the next session, sir?
100%.
Sorry, sir.
Yeah.
Sorry.
Thank you so much.
Okay.
Thank you so much. God bless all of you.
Okay, thank you, everybody. And thank you very much. So now we have a talk by Dr. Suresh Ramalingam, and he's going to talk on role of anti-EGFR agents in lung cancer and what have we achieved as far as goals are concerned since these anti-EGFR agents are around us for last about 8 to 10 years, I would say. So Dr. Ramalingam, please.
Good morning, good evening to you. Let me share my screen. Great. Well, thank you so much for the opportunity to talk about EGFR and advances we made in lung cancer. It's truly an honor for me to talk to you all. I'm also happy I don't have to debate either of the two previous speakers because I would have been in deep trouble if I had to debate them. Fantastic session. Let me start. These are my disclosures. We have come a long way when it comes to EGFR biology and how that has been leveraged to take care of patients. As you are very well aware of, the first description of the activating mutation was in the year 2004. Until then, we were using EGFR inhibitors in a very unselected manner without knowing why some patients do really well and most patients don't respond at all. Thankfully, once we found out that exon 19 or exon 21 mutations result in increased sensitivity to inhibitors, we started seeing a whole new wave of new approaches for treating EGFR mutated lung cancer. We now know about resistance, we now know about various generations of EGFR inhibitors, and we're now moving EGFR inhibitors into the adjuvant therapy setting to improve potentially the cure of early stage non-small cell lung cancer. Now, in the interest of time, I'll focus just on metastatic disease, and perhaps we can talk about the adjuvant data in the upcoming panel discussion. We have in our disposal 3 generations of EGFR inhibitors, and these have distinct differences from one class of drugs to the other. The first generation drugs are reversible inhibitors. They do not have sufficient CNS penetration. They don't have selectivity to the mutated receptor, so they inhibit both the wild type and the mutant receptor. So we do see skin and GI toxicity. Regardless, they were very effective in bringing forth the era of EGFR inhibition and specifically targeted therapy in lung cancers. Then we had the advent of second generation drugs. The purpose of second generation drug was to improve the potency of EGFR inhibition. And they did this by making it irreversible inhibition by covalent binding to the receptor. Well, these drugs are more potent, but they also have less selectivity, and therefore they have severe effects on wild type cells as well, thus resulting in more toxicity with these drugs. And finally, we have the third generation drugs in the clinic, osimertinib being the leader among the class. This drug has both EGFR 19 and 21 inhibitory ability. It also inhibits T790, which we know is the most common escape mechanism for the first and second generation drugs. Osimertinib has better mutant receptor selectivity, over 200-fold more effective against the mutant receptor compared to the wild type receptor. So it gives us the safety profile that our patients appreciate. And finally, it has CNS penetration, and I'll show you some data about that as well. We have now seen a variety of clinical trials that compared chemo versus TKI, TKI versus TKI. And this slide summarizes the progression-free survival results across these trials. And when you look at first and second generation drugs, the median PFS we achieve out of these drugs is approximately 9 to 13 months. And 50 to 60% of the patients will develop T790 when they get first or second generation drugs. Now we have new data that show that osimertinib has superiority over the first generation drugs. And this has now become the preferred frontline therapy. These are the NCCN guidelines from almost a year and a half ago. And you can see for first line therapy, a number of drugs are options, but osimertinib is the only drug that is referred to as the preferred EGFR inhibitor. Now, why is that? Well, the FLORA study is the definitive trial that established the superiority of osimertinib to gefitinib. This study has over 550 patients, one-to-one randomization to osimertinib or gefitinib or erlotinib in the control group. Now, we also allowed patients in the control group to receive osimertinib on progression if they have the T790M mutation. This trial had progression-free survival as the primary endpoint. These are the primary endpoint data, 18.9 months for osimertinib compared to 10.2 months with a very significant hazard ratio of 0.46. We also found that osimertinib had a good safety profile. More recently, we have the survival results. Here are the Kaplan-Meier curves that show that osimertinib is superior. This is actually the first time that we've seen in a TKI to TKI comparison that one drug is superior to the other in terms of overall survival. And you can just look at this as not just an observation relevant for lung cancer, but across the entire realm of solid tumors where TKI to TKI comparisons have not resulted in survival benefit. So we were excited to see the survival benefit, approximately 39 months versus 32 months, favoring osimertinib with a hazard ratio of 0.8. And I think the survival results have firmly entrenched osimertinib in the frontline space. Brain mets, unfortunately, are a common problem in EGFR mutated lung cancers. Nearly 40 to 45% of the patients with EGFR mutated lung cancers will have brain metastases sometime during the course of their illness. So treating them with appropriate drugs that can have sufficient CNS penetration has become important. Leptomeningeal metastases are also a common problem, especially towards the latter half of their treatment course, because resistance in the brain develops to TKIs in the first and second generation classes. And we all know leptomeningeal disease is a frustrating clinical problem to take care of. In the FLORA study, we noticed that patients treated with osimertinib had comparable PFS, whether or not they had brain mets at baseline. And this tells us that the drug has effectiveness against the brain. We also know from both the FLORA study and the AURA3 trial, which was specifically for T790 mutated patients, that CNS responses were seen in a high percentage of patients treated with osimertinib. In the FLORA study, the CNS response rate was close to 90%, and in the AURA3 trial, it was 70%. This gives us confidence now to the extent that when we have patients with sub-centimeter asymptomatic brain mets with newly diagnosed EGFR mutated lung cancer, we defer radiation therapy and start them with targeted therapy and follow the brain lesions closely. And most patients experience clinical regressions in the brain and can avoid or delay the need for stereotactic radiosurgery or gamma knife radiotherapy to the brain lesions. Specifically in leptomeningeal disease, osimertinib has also shown activity. This was the Bloom trial done in Taiwan by Dr. James Yang. They had about 41 patients. I would say that they gave a higher dose of osimertinib at 160 milligram per day, but we believe that even at 80 milligrams, one gets sufficient CNS penetration. They found that for patients with leptomeningeal disease, there was a response rate of nearly 62%, and the median overall survival was respectable at about 11 months. So this tells us that we can use osimertinib in patients with brain metastases. So for all these reasons, osimertinib has emerged as the preferred frontline agent. Now, the next step is how can we improve upon the effectiveness of osimertinib and other agents of this class? What can we do to delay the emergence of acquired resistance? One such strategy is EGFR inhibition with combination of anti-VEGF therapies. We now have a number of studies. This is the Relay trial, which used ramucirumab in combination with erlotinib. Now, ramucirumab is a VEGF R2-directed monoclonal antibody. This trial excluded patients with brain metastases, and they showed improvement in progression-free survival, favoring group has a better prognosis patients since they excluded patients with brain mets. We don't have the survival results from this trial yet, and those are eagerly awaited. We also know that osimertinib and bevacizumab is being studied in the frontline setting. This is a trial from Memorial Sloan Kettering, where in a group of 49 patients, they saw a median PFS about 19 months. They saw a high rate of ctDNA clearance in the plasma, and this is now being studied in a phase 3 clinical trial through ECOG-ACRIN. This trial randomizes patients to osimertinib or osimertinib plus bevacizumab. So at this point, this combination is still experimental. I do not use the anti-VEGF combination in my clinic for routine patient care. What about combining chemo with TKI? There's clearly a resurgence of interest in this particular topic. This is based on 2 trials. The first trial, of course, is very familiar to the Indian audience, led by Dr. Narona from Tata Memorial. This trial used gefitinib in combination with carboplatin pemetrexed and compared it to gefitinib in EGFR mutated patients. We saw an improvement in progression-free survival and an improvement in overall survival with a very respectable hazard ratio of approximately 0.45 for overall survival. We also saw similar results in a trial done in Japan. Again, chemo with gefitinib versus gefitinib alone. And there was improvement in survival. It says my time is up. I thought I was speaking for 20.
No, sir. I think it's showing wrong. We may continue.
This showed that chemo plus gefitinib could be a useful option in patients. There is an ongoing trial that looks at chemo plus osimertinib. I think this speaks to the concept of persister cells. We know that when we treat patients with gefitinib or erlotinib or any EGFR TKI for that matter, there is a subclone of cells that are not sensitive. And those are the ones that subsequently progress and cause clinical problems. By using chemo, we have a greater chance of eliminating But in settings where osimertinib is not available, either it's not approved or it's not cost affordable for a given patient, then I think it's reasonable to give the chemo plus gefitinib combination. This is the schema for the FLORA-2 trial using osimertinib plus platinum pemetrexed regimen compared to osimertinib alone. And this trial is accruing well, and we hope to see the results in the next year or 2. immune checkpoint inhibitors. However, in patients with oncogene-driven tumors like EGFR or ALK-positive patients, these drugs do not work very well. We know that from a variety of lines of evidence. This is a meta-analysis that looked at trials that compared PD-1 or PD-L1 inhibitors to docetaxel in the salvage therapy setting. And we know that all of these trials showed significant improvement in overall survival for patients treated with immune checkpoint inhibition. However, when you break these patients down based on their EGFR mutation status, in the top half of the slide, you see the outcomes for EGFR wild-type tumors. There, the hazard ratio clearly favors the use of immune checkpoint inhibition. However, when you have patients with EGFR mutation noted in the lower part of the slide, the hazard ratios favor chemotherapy. In fact, when we give immune checkpoint inhibitors to patients with EGFR mutated disease, the response rate is often close to zero. There was a study done by our colleagues in UCLA in California where they gave immune therapy to patients with EGFR mutation in the first-line therapy instead of EGFR TKI. They wanted to see whether if a patient has high PD-L1 expression, if you gave them immunotherapy, they would do better rather than giving them TKI. And in fact, they had to shut down the study after just enrolling 12 patients because there were zero responses. And therefore, we do not recommend using immunotherapy as single agents in EGFR mutated disease. Now, there is some suggestion that if you give chemo plus immunotherapy, that could perhaps be beneficial in this setting. This was based on a post hoc analysis from the Empower 150 trial. Here, patients received chemotherapy with bevacizumab plus atezolizumab. And this was done for a group of patients, regardless of whether they had the mutations positivity or not. They went back and looked at the subset of about 100 odd patients who had EGFR mutation. And they found that if patients got chemo plus bev plus atezolizumab and had an EGFR mutation, there was a favorable PFS and a trend towards favorable survival for this group of patients. So in Europe, the combination of chemo plus atezo plus bev has received approval from the EMEA for use in patients who develop acquired resistance to EGFR TKI therapy. So again, I would emphasize the point that for EGFR mutated patients, we still go with EGFR TKI. And once they develop acquired resistance, one could consider this 4-drug regimen. Now, in my impression, subset analysis cannot define new standards of care. This is an interesting analysis. This still has to be prospectively verified. Interestingly, in this study, there was another arm where patients just got chemo and atezo without bevacizumab. And that combination was not better than chemo and bevacizumab for patients with EGFR mutation. So just chemo and PD-L1 inhibitor was not helpful. They needed bevacizumab. The good news is there are some prospective trials in this space that are ongoing. We should be hearing about these results in the next year or so, and that should inform our practice. At this point, I do not use this regimen in my practice. There are severe toxicities when TKIs are combined with PD-1 inhibitors. So what I would say here is that in this group, people looked at sequential administration of TKI and PD-1 inhibitors. And essentially, because the PD-1 inhibitors have long half-life, when a patient is started with PD-1 inhibitor and then switched to TKI, they're exposed to both of these drugs, and this results in serious pulmonary toxicities. So I would urge caution before people start PD-1 inhibitors and then immediately switch them to TKI because of toxicity. Now, you can always do the other sequence. You can treat patients with TKI and then switch to PD-1 inhibition later on because the TKIs have short half-life, so you're not exposing them to both of these drugs. But sequential TKI plus SBRT. What this means is they gave patients TKI and they also gave SBRT to any.
I think we're getting a technical glitch from Dr. Ramalingam sir's side. Sir, can you hear us?
Yeah, I am hearing.
Dr. Ramalingam, I think
he's in between. His audio is going off.
Yes, yes.
So I think his time is also nearing completion.
Yes.
So what is to be done?
I think
You can
we
send
should.
him a message.
Yeah, I think we can wait. We can wait, sir. In the meanwhile, we'll keep ourselves mute.
I think we lost him now. He'll rejoin again.
So I think we can ask questions to him later on.
We can see him, but I think maybe he's muted.
Yeah.
No.
All right.
Yeah, he's
Sorry,
muted.
can you hear me now?
Yes, sir. Yes, sir.
Yeah.
Okay. Sorry about that. I'm almost towards the end of my presentation, so if it's okay, I can continue on.
Yeah, maybe 1 or 2 minutes, 1 minute. Yes.
Sure. So this is showing favorable outcome with radiotherapy with EGFR TKI. This is a study that has created some discussion. There are some ongoing trials studying similar concept. This is something to keep our eyes out for in the future. Finally, we're beginning to understand the resistance mechanism to osimertinib therapy. This is plasma data. We see secondary EGFR mutations in about 10% of the patients, MET amplifications in about 15% of the patients. And we're beginning to use this information to drive combination therapies in the setting of acquired resistance. Are now moving towards managing acquired resistance. Combination approaches are exciting. We're also beginning to look at them in adjuvant therapy setting. Let me stop there. Thank you so much, and happy to participate in the panel discussion and answer questions.
Thank you very
much, Dr. Suresh Ramalingam, for the excellent presentation about TKIs and about immunotherapy also, and the combination of various therapies. Very nicely presented. The next session is on
Dr. Anand, sir. Sir, we would like you to facilitate Dr. Ramalingam, sir, with the online memento, sir.
Yeah, please.
Sir, it's visible on the screen, sir. You can facilitate him.
Yeah. Okay. So how this will go online?
Yes, sir. So we'll send it by email, sir.
Yeah. So we are very happy, and from on behalf of the organizing committee of Paras Cancer Conclave, it's my pleasure to hand over this memento, and it says your name as well as your topic, and we are very happy to present it to you and hope for some future collaboration with you on these topics. Thank you very much for spending your time for this conference. Thank you very much.
Thank you very much.
Thank you. Thank you, sir. So you can continue, sir. Thank you.
So we are coming to the end of this session, and but a very important part is left, and that is a panel discussion, which should be, I feel, should be very hot, and a lot of topics are going to be discussed on metastatic lung cancer. And we have Dr. Ranga Rao, who will be coordinating this session, and I invite him to call upon all the panelists and start his panel discussion. Dr. Ranga Rao, please.
Yeah, thank you very much, everyone. And then I would like to share my slides here. Right, thank you. So I'll call upon each and every panelist here. Let me call out the panelists. So Dr. Suresh Ramalingam, we just heard, and let me also introduce that he is one of the original investigator of the FLORA trial, and he's so well read and so well thorough research in the lung cancer. It's such a big honor to have him in the panel. Dr. Suresh Lingam may please join. And then we have another stalwart from India, Dr. Navneet Singh. And if you type lung cancer and India, his name comes probably one of the top ones. And Dr. Navneet Singh, who's an additional professor from PGI Chandigarh. Kindly join us, Dr. Navneet. And then Dr. Rajesh Padidar, who is a consultant medical oncologist from Indore. And Dr. Kuldeep Sharma, Senior Consultant Radiation Oncology from Venkateshwar Hospital, New Delhi. Another colleague of ours, Dr. Shagun Mishra, could join from Lucknow. She's a radiation oncologist. Dr. Kuldeep will have to do for a lot for her. Dr. Anupam Gaba is a nuclear medicine specialist from Panchkula, and Dr. Nupur Gupta is a pathologist from Fortis Hospital in Delhi. So let me start my this thing, right. Right. So we just confining ourselves to EGFR mutated lung cancer. And the points I want to cover quickly are the applicability of the current guidelines in testing, the use of the TKI, the troubleshooting when we have double and multiple mutations, and all the other things like first-line combination therapy, what should be given. Dr. Ramalingam has beautifully covered in his lecture. And then also involvement of the local therapy. He was towards the end, he mentioned it. Maybe we could discuss it. And then messages from the panel, and then question, answers, and conclusions. So applicability and use of current recommendations of the applicable in India, testing in what. So we have Dr. Nupur Gupta, who's a pathologist. The first question is for her as to how good are the samples for the lung biopsy or FNACs, whatever they're doing. I mean, can Dr. Nupur tell us, please? Hello.
Ma'am, please unmute.
Ma'am, please unmute yourself, ma'am.
Yeah. Am I audible now?
Yes, ma'am. Yes, you're audible. Thank you. Please start.
So usually the tissue biopsies which we get are true cut biopsies, guided ones. And only once we look at the H&E slides will we be able to make a primary diagnosis and say whether the tissue is adequate for further testing or not, be it IHC or molecular studies. We also get cell blocks from FNACs, which could be EBUS guided or CT or ultrasound guided, which work equally well.
Right. So we do have
only FNACs, of course, won't work.
Right. So a lot of testing is done, IHC, and then followed by the driver mutation. You have adequate tissues for most of it. Do you have adequate tissues?
Yes.
Okay. Fine.
Sometimes we'll get necrotic biopsies. So our target, if we want to send for mutation studies, is at least 20% of the tissue should have tumor.
Right. And do you also practice sending the liquid biopsy in the beginning?
Not really.
Not really. Okay. So may I ask Dr. Navneet about this practice? I mean, your samples, when you send in your institute, you have adequate samples. Do you also do the liquid biopsy? Do you have problems in adequacy of the tissue? Dr. Navneet, please.
Right. So thank you. I would just like to highlight here that in my institute, PGI, we actually have 4 different pathology departments. And so in the context of lung cancer, there are 2. One is histopathology, which processes biopsies, and one is cytopathology, will process cytology specimens. And so both of these labs, both of these departments have their own labs for molecular testing as well. And the cytopathologists are also sensitized to the fact that the samples need to be processed for both the diagnosis and molecular testing. And hence, whenever tissue is being obtained, a point is made to process or at least make a cell block. And a good cell block, we know, is as good as a biopsy for most molecular testing. We don't do liquid biopsy upfront, primarily because it's not yet available in-house. And if you have adequate tissue which can be processed for the common molecular tests, which is EGFR, ALK, and maybe even ROS1 and PDL1, you may not even need to do further testing based upon the reports. So we have these 4 tests in-house, and we don't do liquid biopsy upfront unless tissue is an issue and the patient is not willing for a rebiopsy.
Right, thank you. So, and then I think what troubles us is the turnaround time of 1 to 2 weeks. And what is your turnaround time to get an answer for this kind of patients?
Yes. So turnaround time typically is 2 to 3 weeks, as you said. I mean, in government institutes, we have a whole set of logistic issues that you have to convince the patient to make the payment, which is not too much, but still sometimes the patient will not end up making the payment at the time the treatment is initiated, and good sort of very cooperative patients will have the molecular testing reports by the time the second cycle is due, but you'll have another set of patients in whom you'll end up getting the molecular reports only by the time the third cycle is due. So those things take time to time, but average, yes, 2 to 3 weeks is the processing time.
Yeah. So Dr. Suresh, I mean, in your institute, such an advanced institute you have, what is the turnaround time to get an answer in a lung cancer patient about the driver mutations?
It's still the 2 to 3 weeks, simply because we have adopted NGS testing with so many targets. We might as well get all the information on step 1. So we do NGS. A lot of logistical factors, just like the ones that Dr. Navneet Singh mentioned. Payment is not as much an issue because it's all insurance driven, but getting the tissue biopsy sample from whichever hospital where the patient had the biopsy done, all those steps go in. So it takes 2 to 3 weeks, and we reassure patients that as long as their clinical course is not rapidly declining, that even the 2 to 3 week delay is not going to be a big problem in the long run of things. Simply because we would want to get the first step of treatment right rather than early.
Right. So I think we have no choice here at the moment. So I think Dr. Suresh Ramlingham has amply clarified the advantages of using the osimertinib in the first line. Dr. Navneet and maybe other medical oncologists here who are there. So can they answer as to, are they using everyone osimertinib, or is it because cost is inhibiting them from using this? Dr. Rajesh?
Sir, hardly 5 to 10% are able to get osimertinib because cost is an issue here. Many a times we'll end up giving combination of TKI with chemotherapy since it has given.
So I think that's an adequate compensation for using the. So you're using the first line TKI along with the chemotherapy based on the Tata Memorial study. That we have,
yes,
right?
we have started using.
Okay, fine.
Yeah, so I mean, I agree. I mean, the percentage of eligible patients who can actually afford osimertinib upfront is less than 5%, probably even lesser. And so whenever we get patients who are newly diagnosed with EGFR mutated metastatic NSCLC, we offer them all the treatment options, right from first generation, second generation, third generation, and the combo. Typically fit patients, younger patients who are willing to get the combination of the gefitinib and PEM carbo will go on to that. Elderly, frail patients will probably just get either the first generation or the second generation EGFR monotherapy.
Right. Okay, so we'll have to wait for the osimertinib to be much cheaper than what it is. I think that will solve a lot of problems. Do we have any mutation-specific therapy I mean, do you go through the mutation analysis and then think of the drug that to be used, Dr. Rajesh, or Dr. Navneet also?
So I think one area where the data is pretty much clear is the uncommon mutations. So I think the best data is for afatinib, the second generation irreversible pan EGFR pan ERBB blocker. And so whenever we get L861Q exon 21 or the S768I exon 20 or the G719X exon 18s, we typically offer them afatinib. I know that there is a phase 2 trial for osimertinib as well, but I guess the data is greatest for afatinib, and that is one scenario in which you would probably not want to use the first or the second generation. I mean, you would not want to use the first generation TKIs. You could still then give them the combo, but if it's monotherapy, it should be afatinib. And we have generic afatinib available now.
Yes, right. Thank you. So I think that will go on. So I just have one question for Dr. Suresh, and this is about the multiple mutations, because sometimes you're doing the NGS in patients, not in all. And when we do that, surprisingly, about 3-4% of the patients do have multiple mutations. And that confuses us to a lot. What is the driver mutation in this patient? Something like EGFR and ALK. Sometimes we get the EGFR and the PDL1 positive. So what does one do in such patients, Dr. Suresh?
Sure. One answer that's easy is EGFR and PDL1 positivity can happen. Majority of the EGFR mutated tumors are PDL1 negative, but sometimes you see high PDL1. But to me, that is not something that changes the decision to give TKI to these patients. Remember, when we're looking at PDL1 positive, we're looking for an inflamed tumor microenvironment. That's what.
Yeah. Does it indicate some bad prognosis, adverse prognosis in such patients, PDL1 positivity? Some audio problem. Maybe not Navneet. Yeah. Sorry, you're back, I think, Dr. Suresh.
Okay. So in this case, PDL1 expression levels do not make it more likely that the patient will respond to immunotherapy. So I do not use PDL1 expression as a confounding issue here. The double mutations, occasionally you see EGFR and ALK together. That usually ends up being a mixed histology tumor, and there is no good answer. I usually give them chemo with a TKI. In this case, a first generation TKI would be appropriate. See how they respond, and then at some point down the line, I might try an ALK inhibitor. But thankfully, those are exceedingly rare.
Right. So I think we have already discussed a lot in your lecture. We heard about combination therapy. So combination of the TKI first or third generation with this thing. Anti-angiogenic also, you said you're not using it. But there is one study which has come in recently of the Saremza and the first, I think, erlotinib. And then that probably is more effective in the exon 21 mutation. Any comments on that, Dr. Suresh?
The study you're referring to, the Relay trial,
yes,
has reported the PFS, but they don't have the overall survival results. Now, when you give an anti-angiogenic drug, you have to give it every 2 to 3 weeks, IV. There are additional side effects. When we give patients targeted therapies, one of the nice things is to be able to tell them, you take the medicine at home, you come every 2 or 3 months and say, see us. With this, I don't think giving the IV drug every 3 weeks is going to be a convenient issue for patients. So if they show improved survival, that certainly would change our thought process at this point. They did show that if patients have concomitant P53 mutation, anti-angiogenic therapy addition helps. And that is a group where we're thinking that EGFR TKIs don't do quite as well. So there may be a subset of patients where the combination is particularly helpful. I don't see this as something we would do for every patient that comes to us. They also showed, as you rightly mentioned, a favorable trend for exon 21s, which does a little less well compared to exon 19s with TKI therapy.
Right. Thank you. And I think we want to delve upon this. You did mention in your slides towards the end, when we were talking about the local therapy in these patients while on TKI, brain mets, I think, is self-explanatory. The oligometastatic disease, oligoresidual, oligoprogressive disease, just wanted to get the view of Dr. Kuldeep Sharma, who is a radiation oncologist. How many patients turn up to you, the metastatic lung cancers for radiation, Dr. Kuldeep?
Thankfully, once things are more clear between the medical oncologist and radiation oncologist, we get quite a number of patients who come to us once they are diagnosed with brain metastases. And brain metastasis is rather one objective thing for which standard reference is made to a radiation oncologist. And apart from that, even bone metastasis patients, they present to us. So you can say out of, if there are 100 patients, around 20 to 30% patients come to us with brain or bone metastasis to our clinics from medical oncology side or from the respiratory side.
Dr. Navneet, what has been your practice? Do you refer them to for the radiation oncologist for the residual lesions or some lesions for radiation ever?
So I think that's going to depend largely on whether you have picked up asymptomatic or symptomatic brain mets.
I'm not talking the brain mets. I'm talking the metastasis elsewhere. We're not discussing.
Okay. So if you have metastatic disease elsewhere, it'll depend what site it is. So for example, if you have liver metastasis, I'm not sure the role of radiation. If you have bony disease, I would always put them on either a bisphosphonate or denosumab, and for multiple painful bony metastasis, also consider palliative radiation. And other sites is going to again largely depend on whether radiation to that particular site is going to make a difference or not.
Right. So, Dr. Suresh, I'd like to ask you, you were showing a very good slide where survival benefit was there when TKI and SBRT was being given. Could you explain that? Because we couldn't hear you at that time because of the audio problems.
Sure. Sorry about the audio issues. The Chinese trial that I briefly referred to had about 130 patients, and they gave SBRT to visible macroscopic disease, and they showed a favorable trend. There were some issues with the trial. Their best survival was 17 months, even for the group that got radiation and the TKI, which is much lower than what we see nowadays. So there are some inherent questions about that particular trial, but the concept, I think, is definitely valid. There is an ongoing study led by our colleagues at MD Anderson that's looking into it. They think it's called the Rainbow Study. And this conversation within the cooperative groups about designing such a study to address this very question. Presently, what I do is if a patient is responding well, I don't use SBRT, but oligoprogression, as it happens, that's managed with SBRT, and patients can continue on with TKI for a longer duration. I do think there's a role for radiation. We just have to define who will benefit and what is the number of metastatic sites one could radiate safely and still not impair the patient's long-term outcomes.
So when the patient has got a residual primary, and then with the metastasis responding quite well, and the local residual disease is somewhat active, do you ever consider a local RT, or you just continue with the TKI?
Yes, that is a case-by-case discussion we have in the tumor board when we discuss difficult situations. When a patient is responding very well at every other site and you have an active primary that hasn't budged, we definitely would consider using radiation in that situation.
Right. So
I have a couple of questions for Dr. Ramalingam. So one is, we know that osimertinib has excellent brain penetration. And so for patients who have not received osimertinib upfront, and you are not able to demonstrate T790M in either liquid biopsy or even a rebiopsy, we know that CSF T790M can still be positive, even though your liquid biopsy ddPCR or your rebiopsy may be negative. Do you still think that osimertinib use for brain metastasis or leptomeningeal disease should still be conditional on demonstration of T790M?
That's one situation where, Navneet, I think if you have a patient on a first or second and the disease progression is primarily in the brain and not in other parts of the body, switching to osimertinib, even without confirmation of T790, could be helpful. So that's definitely something to consider.
And I had one more question, I think that was brought out earlier. So if you have an EGFR mutated patient and a high PD-L1, I'm not asking about immunotherapy. What I'm saying is, do you think that the high PD-L1 sort of makes you take a different approach to treatment? I mean, would it want you to favor an osimertinib versus an EGFR plus TKI combination based on the high PD-L1?
No, high PD-L1 is, I think, a downstream consequence of EGFR activation. It doesn't correlate with interferon gamma signature or a T-cell rich tumor or a hot tumor microenvironment. So in an EGFR mutated patients, the PD-L1 information is somewhat dubious.
Can I make one point?
Yeah, please, Dr.
As Dr. Navneet was questioning that what is the role of radiation in liver metastasis. So there is in oligometastatic disease, if in liver there is 1 or 2 lesions, they are limited lesions, then SBRT can very well be used for liver lesions. There is no doubt in that. And moreover, if there are painful bone lesions, then I think apart from zoledronic acid and bone-directed therapies, radiation should strongly be considered for especially the lytic lesion with a soft tissue component and painful lesions, which are specifically in the weight-bearing areas. So I think a radiation oncologist reference should be specifically taken in those cases.
Right, thank you. I think we are now nearing the end of the whole discussion here. So I'll just have the messages from each one of you. Short
Dr. Mridul had a question in the messages. I just
Yeah, Mridul, please go ahead.
Yes, sir. So a couple of questions. Initially, we were discussing about the tissue sufficiency and sufficiency. So I just wanted to know that what all IHCs are we applying for the diagnosis? Because ultimately we have to preserve the tissue for molecular testing. So that was for the pathologist, and maybe any pathologist can take that. And second question was regarding the coexistence of multiple mutations. So this was for Dr. Suresh Ramalingam, sir, that have they come across both EGFR and ALK coexisting lung cancer patients, and how to treat such patients? Whether we should target with a single EGFR or ALK, or we should give both, or because it is rare to have such mutants to coexist together.
Dr. Nupur, about the IHC.
Yeah. So primarily, first you have to consider the morphology. And since we need to use the tissue judiciously, to preserve the tissue for the further mutational studies, the basic you need to do is a TTF1, an Apsin A, and a P40 at least. If that doesn't give you the answer, then you can go on with the other markers, but that's the basic. If you are looking at an adenocarcinoma, at least which is suggestive morphologically of an adenoCA versus a squamous.
Okay, so I mean, how many markers would you put if all three are negative?
If all three are negative, then you won't go ahead and call it an adenocarcinoma. Then you may see large cells, and you may be suspecting a large cell neuroendocrine, because we're talking about a non-small cell carcinoma here.
Yeah.
Then you may additional squamous markers, but the sensitivity and specificity of P40 is much better than other squamous markers like P63 and CK56, etc. So if a P40 is totally negative, then you don't expect it to be a squamous cell carcinoma. Then you will go ahead and do some neuroendocrine markers then.
Okay, so mainly we do three markers, that is TTF, TTF1, Napsin, and P40.
And P40, yes.
Those
are the ones you'll do definitely, yes.
Okay.
No, can I add here? I mean, this is something which I've learned from my pathology colleagues over the years.
Yes, please.
So if you have a clear-cut squamous morphology on the microscopy, which is like keratin pearls or intercellular bridges, you don't need molecular. You don't need.
No, you don't need IHC at all. So that's the first thing I said. That first is your morphology.
And if you have like glands straight away, you will probably not need to do either TTF1 or anything. So if you have NSCLC and you're not able to make out further, then the ISLC recommendations are to do at least one adenomarker, which is preferably TTF1, and one squamous marker, which is the most sensitive, is P40. And for squamous positivity, you need strong P40 or P63 positivity. Mild positivity can occur in even adenos. So once you have ruled out squamous, you don't really need to do further if your tissue is limited, because all the other non-squamous NSCLCs, you are supposed to test for molecular markers, whether that is adeno or NSCLC.
Dr. Navneet, I'll just add here that it is always prudent to do a TTF1 or an Apsin 1 to make sure this is a lung primary you're dealing with, because sometimes IHC will spring surprises. Clinically and radiologically, initially you'll be thinking you are dealing with a lung primary, but your IHC will prove it to be a secondary, and then additional workup will prove that. So it is always prudent to at least run one adeno marker.
Yeah, I think now we are shooting the time. So one last comment from Dr. Suresh Ramalingam. I think the question was, Mridul, that you asked dual mutations. He said in such cases, a TKI with the chemotherapy would be a good option. So Dr. Suresh, one final comments from you to Indian colleagues, where cost is one problem for testing as well as for the TKI, the third generation TKI.
Yeah, I think testing is still critical, and tissue-based testing still is the standard way to go. I strongly recommend testing for the treatable targets like EGFR and ALK before we start patients on chemo or immunotherapy approaches. only about 60 to 70% of patients, even in the US, get tested for molecular abnormalities, and that's a lost therapeutic opportunity.
Right. Thank you. Anything, Dr. Navneet? I mean, you've done so much of work in India, and then we are so proud of your work. The last
No,
part.
I think just re-emphasize what Dr. Suresh said. We need to test, because if you don't test, you will not know. And if you don't know, you cannot offer that treatment. So you need to test. It's our duty to make sure that anybody who's eligible for testing gets tested.
Right. Fine. Thank you very much for a wonderful panel discussion. Dr. Suresh, we're so honored to have you here. Dr. Navneet and all the panelists here, thank you very much for your wonderful contribution to this panel discussion. Thank you very much. Have a nice, safe times ahead. Right.
Thank you.
Right. Bye-bye. Right. So over to the organizers here. Aditi, you're there.
Yes,
Hi,
sir.
Hi, Dr. Aditi will be taking over for the inaugural now. Aditi?
Yeah, I'm here.
Yeah, you will take over now?
Yeah. Thank you, Praneeth.
Yes.
So, a very good evening to all of you. It is with tremendous pleasure today that I welcome you all to the inaugural ceremony of the first ever Paras Cancer Conclave 2021, which is a 3-day virtual event conducted from 19th to 21st of March. On behalf of the entire organizing team, I welcome our chief guest, Dr. Rath, Chief NCI AIMS, our guest of honor, Dr. C.S. Pramesh, Director TMH Mumbai, Dr. Dharmender Nagar, Managing Director, Paras Group of Hospitals, Dr. Shankar Narang, COO, Paras Group of Hospitals, Dr. V.S. Mehta, Director, Paras Institute of Neurosciences, Dr. R. Rangarao, Chairman, Paras Group of Hospitals, Dr. Alka Kriplani, Director and Head Center of Minimally Invasive Gynae Obs and ART, Dr. Khandelwal, Director, Surgical Gastroenterology and Oncology at Paras Patna, Dr. Rajeshwar Singh, Director, Medical Oncology, Paras Panchkula. I extend a very warm welcome to our international faculties, Dr. Suresh Ramalingam, Atlanta, Dr. Amit Kumar Mehta from Birmingham, Dr. Domenico Genovesi from Italy, Dr. Shahina Dawood from UAE, Dr. Nitya Bakshi, Dr. Shaji, as well as to all faculty from Nepal and Bangladesh. I also welcome our national faculties from different parts of the country who have graced the program with their presence and accepted to share their experience with delegates. I wish to extend a very warm welcome to all the delegates from India as well as neighboring countries, including Nepal, Bangladesh, Russia, Nigeria, Kenya, US, and Europe. I also welcome our sponsors and their teams, Paras team, including marketing, branding, corporate teams, coordinators, and all our viewers who have joined us today to grace this inaugural session. So as it is our holy tradition to worship our goddess Saraswati before any important event, so let's dedicate a prayer to Ma Saraswati in the form of Saraswati Vandana and a virtual lamp lighting by our dignitaries.
Kurutvang kalyanam arogyam dhanasampadam shubham kurutvang kalyanam arogyam dhanasampadam shatru buddhi vinashaya dipajyotir namostute dipajyotir namostute shubham kurutvang kalyanam arogyam dhanasampadam shubham kurutvang kalyanam arogyam dhanasampadam.
Now, after the Saraswati Vandana, I would like to invite Dr. Abhishek Anand, who is the Consultant Medical Oncology, Paras Patna, to say a few words about the Paras Cancer Conclave.
A very good evening to all the esteemed guests, faculties, and delegates. Paras Cancer Conclave 2021 is the first virtual meet jointly organized by the 3 Paras Cancer Center at Gurgaon, Panchkula, and Patna. The theme for this year is redefining cancer care for the next decade. It is a joint effort by all the members of Paras Cancer Center, including all the doctors and the technical as well as the management staff. It is a virtual academic meet of around 40 hours, span over 3 days from 19th to 21st of March. A separate hall has been designated for our primary care physicians as we understand their importance in cancer management, especially during the follow-up after completion of the cancer treatment. The conclave has tried to cover all the disciplines, including head and neck cancer, lung cancer, gastrointestinal cancer, urology, gynecology, pediatrics, hematology, and most importantly, the genetic and familial part, which is neglected in most of the time. Most of the topics included throughout the conference are related to new and practice-changing updates in the last decade in the field of oncology, including the surgical, radiation, as well as the medical oncology. We have also included workshops in various specialties related to cancer management and quiz competitions for the delegates. Faculties from all over the world, including USA, UAE, Italy, Germany, Bangladesh, and many other countries have participated in this event. Many of our national faculties are also part of this mega academic fest to share their experience in managing cancer patients. We feel extremely glad to share that we have got more than 8,000 registration for the event. And on the first day, the peak attendance was more than 800. In future also, we will be continuing with such kind of meetings as well as organ specific CME on a regular basis. With this, I would like to thank you all for joining and making it a successful event. Thank you. Over to you, Dr. Aditi.
Thank you, Dr. Abhishek. I would now like to invite Dr. Shankar Narang, the COO, Paris Group of Hospitals. Dr. Narang did his MD from Moscow State Medical University and MPhil from BITS Pilani and has been instrumental in not just the initial phase of Paris Gurgaon, but also in overseeing operations at all hospitals and healthcare verticals of Paris Group, including Paris Hospitals and Paris Cancer Center. Over to you, sir.
Good evening and a warm greetings from the Paris family. It gives us immense pleasure to be part of this August gathering this evening. Just to share with you all, we started our journey in 2004 with the planning of our first hospital in Gurgaon. And today, almost 1.5 decades now, we stand strong with 6 hospitals, more than 1,200 beds, 600 plus doctors, and 3,000 plus medical and paramedical staff working with us at different locations and different states. At Paras Healthcare, we strongly believe in our vision and mission of ensuring accessible, affordable, quality healthcare to each and everyone, even in the rural and remote regions of our country. That has been the vision of our managing director in propelling this organization today, tomorrow, and in future times to come. And to ensure the quality healthcare, one of the most important building blocks we understand is the academics. With that thought and zeal, we in all our 6 hospitals since last 15 years of our existence have been year on year doing programs which help us in growth of the knowledge of all our forces, whether doctors, nurses, or other paramedical personnel and non-medical people working with us in helping delivering quality services to our patients. We run several DNB programs. We run other academic programs like diplomas and degrees in emergency medicine, critical care, minimal invasive surgeries, spine surgeries. Similarly, Paras Cancer Conclave is also part of one of the such academic activity. I have been part of some of the meetings of the organizing committee and was very impressed with the enthusiasm and the efforts being put by them in spite of their busy schedules and taking out time from doing what they do best is treating the patients. All these efforts have been put into impart the knowledge to the fellow colleagues, and it is not only, I would say, a teaching exercise, but also a big learning exercise for ourselves also. I wish you all and this Paras Cancer Conclave to be a platform for a lot of our young colleagues to gain from the experiences of the seniors and stalwarts of this field. Best of luck and a very good evening, and thank you.
Thank you so much, sir. Thank you for your encouraging words and always being so supportive in whatever we have done, right from the conception of Paris Cancer Conclave or be it any clinical activity. So now I would like to invite Dr. Ranga Rao, who is the chairman, Paris Cancer Center, Paris Hospitals, a leader, a visionary, and a sensitive clinician. Dr. Rao has been instrumental in getting Paris Cancer Conclave to the present form that is visible to all today. It was his brainchild and under his guidance that the meeting has achieved the current form that we all can see today. Over to you, sir.
Thank you very much, Dr. Aditi, for being so generous in your comments. And thank you very much, everyone, for joining us here. Dear Dr. Ratsa, Dr. Pramesh, Dr. Nagar, Dr. Shankar, distinguished faculty, delegates from all corners of the country and the world, and friends who are viewing from all the digital media from various parts of the country. A warm greetings to you all from Paris Healthcare and Paris Cancer Centers. Pursuing the vision of Paris Healthcare, which has just been told to you by Dr. Shankar, to become one of the most favored healthcare destinations and chains across North India, the three Paris Cancer Centers located at Patna, Panchkula, and Gurugram have imbibed the ethos in letter and spirit. They have established themselves in a very unique position with many firsts and bests in their places. The milestones of the team have been well spread and strong, paving the way to a path of excellence, personalized care, and patient-centric approach, matching the zeal and the enthusiasm of the Paris Healthcare vision and mission. Having treated over 1 lakh cancer patients across all the three centers is one of the simple milestones. And then we have a long way to go, we understand. We are also a part of the NCRP, that's the National Cancer Registry Program. We just have begun, and also the virtual tumor boards, which are hosted by the National Cancer Grid. Apart from being providing the cancer care at our hospitals, we're also endeavoring to reach the people at their doorstep, in their villages, in their towns, through a network of hospitals and camps and awareness drives. We were inhibited by the COVID, but now we are on full strength as long as the COVID permits us to do that. All the three centers have very well trained and experienced oncologists of all disciplines and are able to provide the optimal care to the cancer patients at a moderate cost. The centers have state-of-the-art facilities with well-equipped supporting professional and administrative departments. Strong academics in the form of the virtual tumor boards, which we have been having very regularly, not only in our own units, but also across all three centers. Multidisciplinary meetings, review of recent advances in various forums continue to power and update them with scientific tools of delivery of cancer care. This event of first Paris Cancer Conclave is just one of them to demonstrate their teamwork and their commitment to strong academics. We're proud to announce that we have had over 8,000 registrations, peak attendance of over 1,000 yesterday, and around 800 are watching right now in 4 halls packed with sessions from reputed national and international faculty. You've just witnessed fantastic sessions in the lung cancer, gynecological cancer, lymphomas, and so on. Despite the recent COVID pandemic and the flash floods which we had in Gurgaon and the resultant damage to the new machines, our management unhesitantly procured new machines at Gurugram, which are in the final steps of installation. That's the PET scan and the TrueBeam machine. And we have successfully carried out the first autologous bone marrow transplant to join the elite group of the BMT centers in the country. Our team has been there to deliver out-of-box solution to our patients from near and far. Bone marrow transplants at Patna, Panchkula, specialized orthopedic surgeries, including the limb conservative surgeries, high volume of HIPEC and PIPEC, the high volume of high-end breast care, specialized radiotherapy techniques, call it anything, and that's there with us. Administration of all kinds of chemotherapy, immunotherapy are some of the examples. Highly experienced neurosurgical team headed by Dr. V.S. Mehta, who's world renowned with his skills and his team. Vastly experienced CNS gynecology team, that is Dr. Alka here. And then urological, gastrointestinal, pulmonology teams have made their place and are helping us out a lot. And then they have been really of a great support to us and give their expertise. Backed by well-established pathology, radiology services, the nuclear medicine services, amidst superb infrastructure in each and every unit under one roof, make the Paris Cancer Centers and Paris Healthcare a unique health and cancer care provider. Oncologists of Paris Cancer Centers, despite the distances, current pandemic situations, are more than ever committed to excellent personalized care based on the evidence and experience to our patients. Thank you very much, each and every one of you, for great support, not just in the conference and otherwise, also for being here and providing us advice. Thank you very much. Have wonderful deliberations.
Thank you, sir, for giving such a good overview, and it was a very extensive deliberation. It was quite promptly given. And I would now like to invite Dr. Rajeshwar and Dr. Khandelwal to chair the session for the keynote address. Dr. Rajeshwar is Director Medical Oncology at Paras Panchkula, and Dr. Khandelwal is Director Surgical Gastroenterology and Oncology at Paras Patna. I would request Dr. Rajeshwar to invite Dr. Pramesh for the keynote address.
Thank you, Dr. Aditi.
I am audible. Hello, am I audible, please?
Yes,
Yes, sir, you're audible.
Yeah, so we move on to a very important session now, and we have two keynote speakers. So first, Dr. C.S. Pramesh. Now, the less I talk is, I mean, he's got so much in his CV. After doing his surgical oncology from TMH, he did his fellowship in thoracic oncology from TMH and did stints in Memorial Sloan Kettering and Crome, Japan. He's a director, professor, and head of thoracic surgery at TMH. He's a visiting prof in the King College, London. He has vast amount of research in innovative management of esophageal, lung, and chest tumor, especially with emphasis on minimal invasive surgery. He's a principal investigator in number of trials, both national as well as international. And in fact, he has done in postgraduate diploma in clinical trial from London School of Tropical Medicine. Now, he's a convener of National Cancer Grid also, which consists of more than 200 cancer centers to provide uniform cancer treatment in our country. He has more than 200 peer-reviewed publications, as well as many chapters in the textbooks in oncology as well as thoracic surgery. So I think he's a right kind of person to talk about the cancer care in India in the next decade. Where do we stand now? So I now invite Professor C.S. Pramesh to deliver his talk, please.
Thank you. Thank you to the chairpersons for this generous introduction. I'll take this opportunity to thank the organizers, the Paras group of hospitals, Professor Khandelwal, Professor Rangarao, Dr. Shankar Narang, and Dr. Aditi Agarwal for this opportunity to speak at this very important meeting. So I'll share my screen now, which will try to address what the organizers have asked me to do, which is to look at what are the areas of cancer care in the last decade that have changed practice in cancer. So if you will just give me a minute. Are you able to see my screen now?
No, sir.
Not yet.
No, sir. Not yet.
Okay, just please, apologies for this. Let me just
Aditi, do we have their slide, please?
So maybe you can mail the slides and we can play from our end.
sure, I can do that. should I do it to your email ID, Aditi?
Sir, Paras Cancer Conclave.
Yeah, I will do that. Apologies for this. I should have checked this before. In the interest of time, do you want to go ahead with Dr. Rath's talk and then do this later?
Yeah, I think Dr. Khandelwal, please kindly introduce the speaker, please.
Yeah. So,
okay with me.
Dr. G.K. Rath. Yeah, Professor G.K. Rath. It is my pleasure, friends, to introduce who is already known not only in the country but throughout the many places in the world, is Professor G.K. Rath. The only such institution in the country, that is National Cancer Institute in Jhajjar. He is the head of that hospital institute. He is the chief of Dr. Ambedkar Institute, Rotary Cancer Hospital, and professor of Department of Radiation Oncology in AIIMS, Delhi. In fact, it is his biodata is too long, but everyone knows about him, including me. I know him for last at least 30 years. It is my privilege that I am to introduce him. So I welcome Professor G.K. Rath, and I request him, if he is prepared, to address us and to bless us with his wisdom of knowledge. Thank you.
Thank you. Tarun, will you show the slides? Tarun?
Yes, sir, we will do that, sir.
So nice of you. Thank you. Great. Thank you. The slides which I'm going to show and what I'm going to talk now, you will be, at the end of my talk, you will be convinced that unlike other non-communicable diseases we face today, like diabetes, hypertension, and other non-communicable diseases, cancer is a very typical, excellent model for both prevention, early diagnosis, and cure. Because diabetes, hypertension, thyroid disease, they neither can be totally prevented or totally cured, but cancer can be prevented up to 60%, cured up to 60%. Next one. What I'm going to do today is to tell in a short span of time is what has already been done and what is being done and what are the gaps and challenges. Next one. In a LMIC like India, major cancers are preventable. I'm giving you some example like tobacco-related cancers and infection-related cancers, which are totally preventable. You know, in our own state of Punjab, we do not have oral cancers. So the example is there in our country. And let me tell you, India is basically a lab for cancer prevention and epidemiology. Because as you will see in the subsequent slides, you'll see that in our own country, from the lowest incidence in Barsi to the highest incidence in Aizawl, the cancer is 7 times difference. So we know what are the causes of cancer, particularly in India. Next one. If you see these, the cases in Asia are 60% and mortality also is 60%. Whereas in Europe, it's 9% and mortality is 20%. If you go to America, it is 14%. So this is a clue that we have to do something about it. And let me tell you, the scene is not bad. We have done fantastic efforts. And you will see from the sites that we have got a lot of things achieved in last several decades with the cooperation of all of us in this audience. 8,000 people have registered. And I can assure you that if we all work together, almost 60% can be prevented. Out of 14 lakh new cancer cases, 8 lakhs can be prevented in India. Next one. This is the cancer burden in India, as you know, which is gradually rising. By 2035, it's almost going to become double. Next one. And if you see the distribution of comprehensive cancer centers in India, it's very, very less, 0.4 per million population. If you see the radiotherapy distribution for 1 million people, it should be ideally 1 in a developing country, but here it's 0.4 per million people compared to 10 per million in Canada and Australia, and 4 per million in US and UK. And as you see here, the centers are distributed mostly in the western part of the country and southern part of the country. East, northeast are really lacking. Next one. If you see the distribution of radiotherapy, it's a similar effect. Today, we have 650 radiotherapy units in the country, out of which only 30 to 40% are in the eastern region of the country or northern region of the country. Major portion is in the southern and western part of the country. Next one. And if you see the oncology workforce, there is a lot to be desired, and we need to, all of us need to work a lot, but these are all which will take time. What I'm going to stress on in my presentation is the need for prevention and early diagnosis in a developing country like India. Next one, please. This is a publication which came in 2019, Lancet Oncology, and that has really told that in HMICs, cancer has overtaken cardiac as the major cause of death. So that's a warning for all of us that very soon cancer is going to be #1 killer in India too. Next one, please. This is another interesting slide which is showing very clearly that about the global scenario, we in LMICs have 60% of cases, and the resources available to LMICs are only 5%. And by 2035, the cases are going to double. So this is a big, big warning, and we have to do something about it. I'm sure all of us agree that we cannot spend much on the management aspect. So we have to focus on prevention and early diagnosis, which is really very, very economical. Next one. This is our figure published in 2020 by the ICMR, which is now NCDIR from Bangalore. And as you see clearly, this itself shows what is the cause of cancer in India. If you see the both male and female, the northeastern region are the main sites where cancers are. As you know, let me tell you first that only 10% of population in the country is included in the cancer registration process. What I am telling you here and what has been published in 2020 by ICMR is only from 36 population-based cancer registries consisting of only 10% of population. Now, there also we need to work hard for registration of cancer and making it a notifiable disease. As you see, there is a 7-time difference in the country itself. And why it is so? Next one. Mostly because of preventable cancers. This is a very positive slide, what has already been done in our country by all of us who are attending the conference and all who are not present in this conference also. You see, except breast, where there is no change in the negative direction. That means the incidence is not coming down. Otherwise, if you see, by all our efforts, major cancers are coming down. Cervical cancer from 40 years back, it was 40 per 100,000. Today, it's 10 per 100,000. So very, very positive sign. Oral cancer, stomach cancer, all are coming down, but we can't tell as a country. These are in specific registries which are showing this, but breast is a thing which we need to, as you know, prevention is difficult, early diagnosis is possible, probably except breast. Everywhere we can focus on early diagnosis, and in breast, we can focus on the, not prevention, but early diagnosis. Next one, please. What have been our major achievements in this country? We have really achieved quite a lot in this country, and we can achieve a lot. See, NCRP, as you just heard, is part of NCDIR, a flagship program of ICMR, and this constitutes, besides cancer, stroke, diabetes, and hypertension. And we have a vibrant national cancer control program of the Government of India. It's part of NPCDCS, again covering all the 4 non-communicable diseases for better applicability. Cervical cancer has come down significantly, but still that, because our population is increasing, today we have 100,000 cervical cancer in this country. It should be coming down to maybe 10,000 if we all try by vaccination, by early diagnosis. Stage migration is really happening. Cancer control is a reality now. Now the government is giving 120 crores for state cancer institutes and 45 crores for tertiary cancer centers. Cancer research has become priority. As you see, a lot of cancer research centers coming up, and there is a National Cancer Institute in Delhi. There is a National Cancer Institute coming up in Calcutta also. 3 main cancers, oral, cervix, and breast. We have been all public is listening to, reading Western data, but the Indian Council of Medical Research, with collaboration of all of us, has published the pattern of care and survival studies of 3 major cancers. Now we can say that we have Indian data, and results, let me tell you, are similar to ways, stage by stage. It's unfortunate that most of our present, in fact, present beyond stage 4, you can tell them stage 10 or 11. What is a 20 centimeter tumor, which the West doesn't see? So that's a very important thing. Next one, please. Yeah, you will be, this is another fit in our cap where this is the WHO report, and you will be happy to know that the aim of tobacco control, this is from WHO, as you see, aim of tobacco control in India, what was supposed to be achieved by 2025 has already been achieved. So 2 major things, cervical cancer control and oral cancer, tobacco related cancer control is already happening. Next one, please. Tarun, next one. Yeah. See, if we do all this, then the 5-year, this is for our residents. This one could see this slide. It's an old slide, but there's no other publication after I could find. 5-year cure rate. 5-year cure rate are continuously increasing. And if you detect in stage 1, this is a publication of 2010, JCO, December. If you see here, the prostate cancer survival is 100%. Breast is 90%. Testis is 90%. Who says cancer is not curable? But can you say the same thing about diabetes, hypertension, or thyroid? So cancer, this is again a publication 11 years back. So if we detect it early stages, it is curable. So we must tell our residents that they must focus on prevention. Next one, please. This is our publication from India on breast, Journal of Global Oncology. Next, please. Cervix, and next, please. Head and neck. The next one. Retinoblastoma also. Next one. Cervical cancer. Next one. And Government of India has opened a National Cancer Institute in 2 places. One in AIMS, under AIMS in Haryana itself, where we are attending this conference. It is the largest cancer center in India, the highest investment in a single project. 2,035 crores have already been invested. And the main focus, as we all realize, is Translational Cancer Research Center, concentrating on particularly India-centric cancers. What are India-centric cancers? Gallbladder cancers are not seen in the West too much. We have the 2nd highest incidence of gallbladder cancer, next to Chile. And oral cancer, cervical cancer are totally preventable. So that's what we're going to do. The other things we are going to achieve here is the MD, PhD, a combined degree to produce clinical scientists. Next one, please. There's a photo. Next one, please. Well, there is an Indian Cancer Research Consortium, which had been formed by the Government of India, ICMR, under the Department of Health Research. The purpose is, see, all of us, like this 8,000 participants, all of us are doing research. All of us are publication. There has to be some organization, probably a central one like Department of Health Research, Ministry of Health and Family Welfare, will collate all this data, see the deficiencies, what are the need of our country, and it has already been going in the right direction. 20 projects have already been sanctioned in this. Next one, please. Next one. What are the issues of cancer in India? There are a lot of issues which we need, even though we have achieved a lot of issues which are there. We know we have poverty and illiteracy, out-of-pocket expenditure is quite huge, lack of awareness, inability to get access to healthcare. The patient in late stages, 80-20 formula, 80% come late, out of which 20% is curable, and vice versa. Long travel distance, poorly trained workforce. Major cancer, that's a good news. Major cancers are preventable. Cervical cancer, any cancer, cervical cancer, or any other like hepatocellular cancers, preventable cancer, cervical cancer, tobacco-related cancer. So need of the hour is translational research from bench to bedside for prevention and early diagnosis. Next one, please. Thank you very much.
Thank you, Sharath. Thank you very much for illuminating us.
Thank you, sir, for the wonderful talk. I would now like to request Dr. Khandelwal to please facilitate Dr. Rath virtually. Dr. Nagar to please facilitate Dr. Rath.
It's an honor, sir. It's an honor to have you addressing us. It's such a pleasure to hear you.
Thank you so much.
Aditi, are we ready with the other presentation?
Yes, sir. We can go ahead.
So, Professor Parmesh, kindly proceed with your talk, please.
Thank you. Thank you very much, Professor Khandelwal, and apologies for the tech glitch. Can I have my slides up, please? So while the slides are going up, I'd like to reiterate my gratitude to the Paras Group, Dr. Aditya Agarwal, Professor Khandelwal, Professor Rangarao, and Dr. Shankar Narang for this opportunity. And I think it's actually fortuitous that the tech glitch happened, because while we have heard what the future is in cancer care from the inimitable Professor Rath, I think it's always good to learn from what we've had in the past. And I will use this opportunity to describe cancer care in the last decade. And given the paucity of time, I will restrict myself to our efforts with the National Cancer Grid, which has as its mandate the vision of eliminating disparities in cancer care across the country. Can I have the next slide, please? So the reason we started the National Cancer Grid was this fairly disturbing graphic, or the heat map that we had from 75,000 patients that visited the Tata Memorial Hospital over a 6-month period. So while you might understand the fairly high density of patients coming from the city of Mumbai and the state of Maharashtra, which is pretty close to where we are located, what is disturbing is the large proportion of patients who visited us from and needed to take treatment at Tata Memorial from northern India, including Delhi and several other parts of northern India, eastern India, and northeast India, which is approximately 60% of all of the patients who visit us at the Tata Memorial. So can I have the next slide, please? So what we did was also to look at the projected cancer burden. And as you can see, as in several other low middle income countries in the country, the incidence in about 8 years back when we started the cancer grid was about 1 million. And the projected incidence in 2035 was 1.7 million, almost a doubling of the cancer incidence over just 25 odd years. Next slide, please. In addition, we also had geographic inequities in access, as is described by the earlier heat map that I showed, which clearly showed that the patients in South were much better served with cancer care as compared to patients in the northeastern and the northeastern part of India. Next slide. In addition, we also, next slide, next. In addition, we also have geographic inequities and gaps which were alluded to by the Ernst & Young report in 2015, which showed that most metrics of cancer care, including the number of linear accelerators, the number of dedicated cancer beds, the number of comprehensive cancer centers, as well as the human resource that was available to treat these patients, was approximately half of what the estimated requirement was. Next. It's much easier to understand these human resource crunches through graphic examples. The Tata Memorial Center is a sister institution of the MD Anderson Cancer Center. And next. And while the MD Anderson Cancer Center treats 42,000 patients annually, we treat almost the same number of patients, which is 46,000. Next. While the MD Anderson has 1,700 physicians and researchers to treat these patients, we have just 188. So this clearly demonstrates that the human resource crunch that we are dealing with is a very real one and not just something that is theoretical. Next. So we had to come up with something which is very out of the box and something quite disparate from what we were usually willing to think of. And we needed to look at how we could eliminate these disparities. Next. So about 9 years back, we created this idea of forming a network of cancer centers that were existing within the country and decided to call it the National Cancer Grid. So this is very dissimilar from other similar networks in the world like the NCCN, where the primary mandate is research. For us, the primary mandate was to have uniform standards of care. So about 9 years back, when we decided to create this network, we had 17 of the regional cancer centers getting together in Mumbai to brainstorm on how we could do this. 9 years later, come on, next slide. We have grown to 236 centers, which treat about 750,000 new patients annually. Next, which is approximately, next, 60% of all of India's cancer burden. We also decided that we needed to include research institutions, patient groups, professional societies, and charitable organizations across the country, because these are the stakeholders which contribute towards cancer care in the country. The three pillars on which the National Cancer Grid is built upon is primarily uniform standards of cancer care, developing trained human resource, and to create a ready platform which is available for collaborative, multicentric cancer research. Next. So one of the first things that we did was to do a gap analysis, trying to identify what were the strengths and weaknesses of the cancer centers in the country. Next. So we looked at the growing burden of cancer in India, what was the demography and the epidemiology that we were dealing with, what were the national priorities as well as global research, which cancer research is a very extensive bibliometric study that we did as part of this. And next, but most importantly, we looked at what were the challenges and the solutions looking at the delivery of affordable and equitable cancer care in India. And this was a very elaborate exercise involving over 70 researchers and approximately 2,000 human hours of work, which looked at identifying what were the potential solutions to work towards this ultimate goal of creating affordable and equitable cancer care in the country. Next. The first initiative that we took was to have uniform treatment guidelines. This was an effort to have consensus amongst the National Cancer Grid centers about what approach we should take for common cancers in the country. Next. But what we rapidly realized was that while evidence-based guidelines was one thing, the implementability was something entirely different. So we did this study in collaboration with some of our colleagues in global cancer control, which looked at what was the ability of available frameworks like the ASCO and the ESMO frameworks in evaluating cost and benefit. Next. So what we realized was that this is a complicated graph, and I will not attempt to go through this in much detail given the paucity of time. But what it clearly established was that the ASCO and the ESMO frameworks really did not agree with each other as far as value for money was concerned when it came to cancer treatment. So these were two of the top cancer organizations in the world, but the frameworks that they had as far as value for money was concerned did not actually match each other. Next. Not only did it not match each other, the more worrying aspect was that while you would expect that as the cost of a treatment increases, the benefit that you would bring would also improve. This was actually the reverse. We had an inverse correlation between the cost of treatment as in the outcome that it achieved. So the higher you paid, the worse was the benefit. So the cost of any treatment that was available in cancer treatment did not really correlate to the benefit that it accrued. Next. So we decided, and especially in a situation where the vast majority of expenditure was met out of pocket, 72% of expenditure of healthcare expenditure is met out of pocket, and only 1/5 of the total public health of the expenditure in health is met by public health. This is a very sobering statistic. Next. So we came up with some steps towards identifying those practices which were low value or harmful practices that should be avoided in cancer care. And we came out with this consensus statement of choosing wisely for cancer care in India. Next. which looked at identifying those practices which were harmful or of very low value. And we lent very heavily on the Choosing Wisely USA and the Choosing Wisely Canada recommendations, but we came up with some new suggestions as well. And while some of them might seem to be elementary in an audience like this, these were something that needed to be actually re-emphasized given the cancer practice in India. Next. So last year, and you might see some familiar faces here, Dr. Rath, Dr. Mehrotra, and several other stalwarts in cancer care in the country got together. 250 of India's top oncologists got back together, and next came up with a resource-stratified guidelines for cancer care, which not only takes evidence-based into the account, but also looks at value for money. And this is now being adopted by the National Health Authority, or the Ayushman Bharat, to reimburse care for cancer. Next. We all know that having treatment guidelines is one thing, and implementation is totally another aspect as far as India is concerned. We also started this effort at institutional peer review, which has been in place for the last 6 years. And over the last 6 years, we've reviewed several organizations where we look at an external peer review to look at the strengths and weaknesses of these respective organizations. So this is a fairly elaborate and detailed process, which starts 6 months prior to the actual report, and a team from the NCG centers is created, and it finally culminates in a site visit and a formal review report to the leadership of the organization, which lets them know what the strengths and weaknesses of this of their institution is. And this has been hugely fruitful in being able to implement changes at an institutional level. Next. The other aspect that we focused on was quality assurance, and this is central and focal to all activities of the National Cancer Grid. We started with surgical pathology, which we know is the fulcrum and the basis of which quality is maintained in cancer control in the country. So we have this web-based quality assurance program in surgical pathology. We started off with just H&E sections, but we moved on to immunohistochemistry and molecular pathology as well. It's voluntary. Organizations get this free of cost. And for those of you who have been familiar with the CAP accreditation, the College of American Pathologists accreditation, it's an extremely effort-intensive, time-intensive, and expensive way of getting quality control in pathology. So what we do is offer the same service at a leaner version, completely free of cost to all the cancer centers which are part of the National Cancer Grid. Next. We also realize the challenges that patients have when it comes to getting expert opinions for cancer. So we created this AI machine learning experience, which is called Navya. We partnered with a software company which looks at enabling expert opinions. So all that a patient needs to do or a family needs to do is to upload their reports in whatever format, including DICOM images, pathology reports, pathology images, onto a secure website, which is sent across to an expert opinion expert within the National Cancer Grid, which then offers an expert opinion, and all of which I described happens in a median turnaround time of 24 hours. So far, we've offered close to 40,000 expert opinions across the world. And though we intended this to be for India, we've had several countries being part of this. So far, we've had requests from 48 countries, and surprisingly, 23 of these 48 countries were high-income countries, clearly meaning to show that the need for this is not restricted to low middle-income countries, but is a real problem even in high-income countries. Next. Going on the clear understanding that multidisciplinary team approach is important, we created virtual tumor boards, and this was based on the approach that some of the smaller centers lack the bandwidth to be able to have specialty-based treatment and decision-making. So we created a virtual platform, and this was much before COVID. This has been in place for close to 4 years now, and we've had approximately 650 virtual tumor boards over the last 4 years, which enable experts from across the country to get together and work on a common platform wherein expert opinions are provided in a multidisciplinary approach. Next. We also leverage the numbers that we have to offer what we call a national cancer library. We've been able to negotiate hard with publishers, and we're able to offer charitable and government organizations free access to top journals in cancer at a fraction of the cost that they would otherwise have to. So this is something that's offered free to the NCG members, which fulfill the criteria, and the kind of discounts that we've been able to offer are close to 90%. Next. We also leverage the fact that we are a large group, and we created a discovery tool, which means that several libraries put their resources together and in a perfectly legal way are able to share library resources across the member centers of the National Cancer Group. This has been hugely successful, with thousands of requests having been responded to by the discovery tool. Next. We also take education and dissemination of information seriously. We created a massive open online course, which is on ncgeducation.in, where several educational courses are available across different specialities, which not as big a scale as edX or Coursera, but nevertheless important initiatives when it comes to disseminating educational initiatives. Next. We know that a country as large as India has geographical challenges with travel. So we had a fairly innovative solution to continuing medical education. And when you look at the Northeast India, which is a particularly geographically challenged region, the typical time it would take to travel from Arunachal Pradesh to a city like Mumbai or Delhi would be 2 years, even if you were to travel by air, is 24 to 48 hours. So we flipped the system around, and instead of expecting the oncologists there to travel to these cities, we sent experts within the National Cancer Grid to these cities to enable continuing medical education and pathology. Next. So what we did, you can continue, keep clicking on this, please. So what we did was to create, next. What we did was to create a series of workshops across the National Cancer Grid centers in the Northeast region. You can click 2 or 3 times more, which spanned the, yeah, that's good, thank you. Which spanned the length and breadth of Northeast India and had hands-on workshops in pathology, including grossing, reporting formats, quality assurance, templates for surgical pathology reporting, and provided a series of workshops which were enabling them to have quality control in pathology. Next. We used this platform to have a research ready network of cancer centers. The National Cancer Grid also funds cancer research across the country, provided these criteria are met. One, it needs to be multicentric. We do not fund single center studies. The cancer that is being studied has to be unique or common to India. The intervention that is being studied has to be cost effective, so that if it is proven to be effective, it is readily implementable. All researchers who get funded by the National Cancer Grid have to commit to share their data in the public domain within a year of completing the trial, and it relies heavily on public and patient involvement. Next. We also have a systematic effort at identifying gaps in evidence so that we focus our research efforts, and we call this the National Cancer Research Initiative. Next. We also have some additional initiatives which are looked at easing pain points for clinicians in the country. Given that protected time is a myth rather than a reality for research in India, we created a NCG clinical trials unit and a contract research organization, which helps researchers with the nuts and bolts of conducting research. Study designs, help with biostatistics, regulatory submission, enabling multicentric studies, contracts, insurance, monitoring. All of this is done at a fraction of a cost of a commercial CRO. Next. This is something that we are extremely proud of, a research workshop, which is a boot camp for training and research methods. So the way this workshop works is that participants from across the country come in with a one-page research summary, which is a vague idea in the back of their mind, which gets converted over 6 very intensive workshop days into a full-fledged research protocol, which is ready for ethics submission. There are only 3 such workshops in the world, in addition to the PREDA workshop, one in Vail, California, one in Flims in Europe, and one in Sydney in Australia. And this is the 4th such workshop which offers this kind of training on research methods. Next. Going by the success of the virtual tumor boards, we went ahead with virtual research boards, which continues to mentor these participants in the Credo workshop and ongoing research methods training. And this was based on feedback that we received from the Credo workshop participants, which makes it clear that ongoing mentorship is important. Next. We are happy that we signed an MOU with the Department of Biotechnology. Next. Wherein we agreed to work on cancer research in India as a national initiative, which will jointly fund cancer research, enable capacity building, and formulate training opportunities for research in the country. Next. We are very firm that we will, next please. We are clear that we will not work in silos and work along with organizations in the country. And again, a year back, we signed an MOU with the National Health Authority, wherein the National Cancer Grid guidelines are incorporated into the Ayushman Bharat program. So in cancer, for the first time under the National Cancer Grid, under the National Health Authority, we will have quality standards being a prerequisite to reimbursement under the insurance scheme. Next. Based on requests from several other countries in the world, we established a Center for Global Health, which we called NCG Vishwam, which is a global cancer care effort, which was launched in the IAEA General Council 2 years back, wherein the best practices of the National Cancer Grid is now being offered to several other countries in the world. And I'm happy to say that this has gained traction, and many countries across the world have become part of this effort. Next. Next, please. Some of the future steps, can I go back to the next slide, the previous slide? So some of the future steps that we are looking at is integrated data collection and aggregation. We are working with some tech folks on how we can do that. We are in the process of establishing a rare cancer registry and an exceptional responder registry, both of which will leverage the numbers that we have to create a platform which is available for researchers across the country. We've already completed our first effort at group negotiation for drugs, which has been able to offer drugs at a fraction of the cost which centers would otherwise have. So we've leveraged the fact that we are a large network and enabled these numbers to drive costs down, which we hope will then get passed on.
I think we have lost video.
Voice. We have lost the voice.
Yeah, I think there's a problem with Dr. Pramesh's network. We can wait for a second or two so that
Aditi,
maybe
can you ring them on telephone? Can you ring him on telephone?
How many slides more left?
Gudiya?
Pankaj, how many slides are left?
Only 2 more, actually.
Just show them so that by the time he joins, at least we'll see.
So there is an issue with Dr. Pramesh's network, and he said that he's almost completed his talk. So we can go ahead with the rest of the session, and he'll try to join back for any questions and answers.
You can just show the 2 slides.
So I would now request Dr. Narang to facilitate Dr. Pramesh. I hope he joins back by the time. Yeah, he's here.
Yeah, so I'm back. Yeah, so apologies for the tech issues here. So if there are any questions, I'm happy to take them. Otherwise, that's fine. I'm almost to the end of my talk.
Can show your 2 slides.
So as I mentioned, the group negotiation for drugs is already over, and we've been able to negotiate costs down to a level where it will make cancer care affordable. But we are also working on a robust health technology assessment platform, which will rationalize cancer care in the country. Next. So the next slide, please. So this is the current extent of the National Cancer Grid. As you can see, it fills the length and breadth of the country. And the important aspect here is that initiatives under the National Cancer Grid have the ability to scale up very rapidly in a very short time and can have access to almost 2/3 of patients being treated with cancer. And the second aspect is that we are very, very open and extremely careful about the fact that everything that we develop is in tech terms, open source, and readily available to all patients and all centers which are part of the Cancer Grid. So thank you very much for your attention. And if there is time, happy to take any questions. I'll stop with this. Thank you. You can close the presentation.
Thank you, Dr. Pramesh, for such a lovely, wonderful, illuminating and educative talk you have given. What you and your NCG is doing for the care of the cancer patient in far-flung areas and with affordable care, and what research you are doing, it is a really eye-opener. Thank you very much. May I request Dr. Shankar Narang, the CEO of Paras Group, to facilitate Dr. Pramesh.
Dr. Parmesh, it was an absolute pleasure listening to you and having you with us today evening. Thank you so much.
Thank you. Thank you very much. Thank you very much.
Thank you. Now I hand over the mic to Dr. Aditi for next presentation.
I'll just butt in here, Dr. Pramesh and Dr. Rath. I think absolutely really very, very wonderful deliberations. And then what we will be doing is we'll follow up with the real thing, because though we have given you the virtual mementos, and for the excellent deliberation that you have, you'll be getting the real things in a very short time by courier. Thank you. It's been absolutely illuminating, very, very educative, Dr. Pramesh and Dr. Rath. Very excellent. Thank you very much. I think every oncologist must listen to these deliberations and get motivated from this. Thank you so much.
Thanks a lot.
Right, sir. Thank you, Dr. Khandelwal and Dr. Rajeshwar for chairing the session. And thank you, Dr. Rath and Dr. Pramesh, for the wonderful insights into the past and future of cancer care. Human resource constraint is a real problem, and all of us have felt that at some point of time or the other. But what is commendable is that in spite of that constraint, we have been able to contribute significantly to science. Especially TMH and AIMS are example for the same, and the previous two talks have shown us how. So now I would like to invite Dr. Dharmender Nagar, who is the Managing Director, Paras Group of Hospitals, for a few words. He has the vision to provide the best expertise and infrastructure to the community at large. He is an MPhil in Hospital and Health Systems Management from BITS Pilani and an Execute Management Program in Healthcare Delivery from Harvard Business School. He obtained his diploma from Imperial College London and has been awarded the Entrepreneur for the year 2015 at India Health and Wellness Summit. Over to you, sir.
Good evening, everyone. Can I honestly say it's such a privilege listening to Dr. Rath, Dr. Ramesh. It's an honor to be part of this conclave where national, international faculty have joined, and I hear hundreds and more than 1,000 people are listening to us right now. Can I say it's a privilege and it's an honor. Paras Healthcare started with the motto of serving the middle class, serving patients in North India and East of India, where the provision of healthcare was the least within the country. When healthcare in this country is behind the standards laid down by WHO, the North and East suffer the most. And Dr. Rath and Dr. Ramesh actually proved our hypothesis within their presentations correct, that North and East suffers. Paras Healthcare started its first cancer center in East of India in Patna. And can I tell you, when we started our first PET scan center, I was actually shocked that between NCR and Kolkata, which is a population equivalent of Europe, we were the first PET scan center. It could have been a matter of pride for me, but it was also scary to realize that crores of people don't even have access to basic cancer, forget about treatment, but diagnostics. In a small way, Paras Healthcare is dedicated to providing not only cancer care, but all healthcare in these areas. Just to enumerate what our motto is in Paras Cancer Centers. First of all, we've called ourselves Paras Cancer Centers. We have 3 centers. All these centers work as one. Our motto is not that each individual hospital or each individual cancer center works in isolation. They work together. All the specialists pool in their talent to come up with solutions for the patients. It was a privilege for me recently to participate in one of those tumor boards. I, being a very, very humble, simple MBBS doctor, was privileged enough to participate in that. And what I learned at that tumor board, that our teams not only discussed patients, their technical, clinical issues, but most importantly, our Patna team, Dr. Keshri, Dr. Khandelwal, they raised ethical issues as well. I clearly remember they talked about a patient who was old lady, I suppose 80-year-old, who was getting secondaries. And the question that was asked was, how should we treat the patient? How do we communicate to the patient that if we go further with the treatment, it is not only going to be costly, but it may not help the patient. And I think these values clearly enumerate that we at Paras not only want to treat patients, give them the best services, best quality, but also take care of their financial and mitigate their financial risks. We have the best technology and we have the best talent of doctors available with us. But I think we have a long way to go. I believe Paras Cancer Centers, which are 3 right now with latest technology, should be in dozens, and hopefully we can contribute in a very, very little manner to bridging this gap of cancer care in North and East of India. It's a privilege and an honor to address you and participate in this session. And I look forward to rest of the panelists, rest of the discussions, and hopefully they're very, very productive as I've seen them right now. Thank you so much.
Thank you, sir, for the wonderful words. And now, as our inaugural session is coming to an end, I would like to invite Dr. Parneet Singh, who's a consultant radiation oncology at Panchkula, Paras Panchkula, for the vote of thanks.
Thank you, Dr. Aditi. Thank you very much. So showing gratitude is one of the most simpler and most powerful things humans can do for one another. A very good evening to everyone. I am Dr. Parneet Singh, and I'm very humbled and honored to propose a vote of thanks in such a distinguished and intellectually stimulating gathering. Thank you everyone for being a part of the first Paras Cancer Conclave. It is a very unique experience for us organizing this conference online. When we sat planning for the conference around 3 months back, we didn't realize that it would be such a monumental task. But and we had to get it done in a very short time. But here we are. And I have been given the work of thanking everybody. So I'll begin my vote of thanks with the guest of honors, Dr. G.K. Rath and Dr. C.S. Pramesh, both doyens of oncology care in India. And thank you, sirs, for being part of the conference and sharing your views. I would also like to thank all the faculty members from India, especially from abroad, Dr. Suresh Ramalingam, Dr. Amit Mehta, Dr. Shaina Dawood, Dr. Temfer, Dr. Domenico, and many more. My heartfelt gratitude for being part of the conference and sharing your valuable views. Thank you, everyone. Thank you so much. And then I'd like to thank the delegates, because without their overwhelming support and registrations, and we could not have reached where we are. We had registrations from around 15 countries, including India, US, UK, Russia, Germany, rest of the Europe, our neighbors, Nepal, Bangladesh, Sri Lanka, UAE, Dubai, and from Africa, including Kenya and Nigeria. And without their participation, this conference would not have been such a great success. Also would like to thank everyone who joined us through Facebook Live and through YouTube. Thank you very much. Any gratitude would be incomplete without wholeheartedly thanking our Managing Director, Paras Group, Dr. Dharmendra Nagar, for his constant support and mentorship, sir. Sir, you have been there for us 200%. And without your support and vision, this would not have been possible. Thank you so very much, sir. I would also like to thank Dr. Shankar Narang, the Chief Operating Officer, Paras Group, for his valuable comments and support. I would like to thank our regional heads, Dr. Talat and Dr. Sameer, and also the whole management and the marketing team who have worked very hard and Dr. Khandelwal. Useful. Thank you very much. Without your support, we could not have reached here. Thank you so much. And this being an online conference, the technical partners were very vital in this for the conduct of the conference, and would like to thank Meetings and More, Mr. Garish and his team, Team Horizon, Tarun, and especially Pooja. Thank you so much, guys. Team Madhawks, Mr. Ravi and his team. They have been brilliant. Thank you very much. Our academic partners, Eli Lilly, MSD, BMS, Mylan, Pfizer, and AstraZeneca. I would thank them for this support. Thank you very much. Last but not the least, I would like to thank the family members of the organizing committee team for bearing with us the odd times of meetings we had in the nights and always being very supportive. Pardon me if I have missed anybody who was part of the conference. Your valuable contribution is well appreciated. There are no shortcuts to any place worth going. You all have made a difference. Thank you so much. I would like to end my vote of thanks with the request that we have very stimulating sessions and stimulating and exciting sessions in the next 2 days. So I request the delegates and the faculty members to attend all of them. Thank you. Thank you very much for the opportunity. Thank you.
So as we come to the end of the inaugural session, and thank you, Dr. Paneet. So as we come to the end of the inaugural session, we would now move on to our scientific sessions, and I would like to request all of you to please stay with us, because the scientific sessions would commence as per the schedule in the respective halls, and there will be a quiz in Hall D at the end of the session for the postgraduate students with attractive prizes. And we have a session starting tomorrow at 9:30 a.m. again in 4 halls with very interesting sessions on neuro-oncology, pediatric oncology, GI, genitourinary, and we have some sessions on breakthrough in oncology. So thanking all of you and requesting you to stay with us. Thank you so much. Over to the session coordinators for the hall. Thank you.
Shall we start the proceedings for the hall A again further?
Yes, sir.
Okay, great. So continuing with our lung session. Yes. So I'd like to call upon the chairpersons for the next session, Dr. Sudeep Shrestha. He's the founder and executive chairman, senior consultant and medical oncologist, Nepal Cancer Hospital and Research. He's had many awards in the international and national awards and many many articles in his journals. I would like to also invite Dr. Subhash Ranjan. He is currently a senior consultant medical oncology and sorry, senior and also honorable consultant Indian Armed Forces. Sir, we welcome you all for the next lung session. You can take it from there. Sir? Dr. Sudeep, sir?
Yes.
So you can take it from there, sir.
Thank you, Mr. Pranit. I would also like to thank the organizer for giving me this opportunity to chair this session. This is the second session in lung cancer. So specifically we will be talking about immunotherapy in lung cancer, the new insight. We have four eminent speaker. So I would like to request the first speaker, Dr. Nitesh Rohatgi, will be talking about nivolumab in lung cancer. Dr. Nitesh Rohatgi, please.
Thank you very much, Dr. Rangarao and the team at Paras for doing wonderful meeting. And it was a true revelation to hear Dr. Rath and Dr. Parmesh. I almost feel like leaving what I'm doing and joining both of you or either of you to do something more meaningful in life. Without further ado, I think, can I present my slides or will you be presenting that?
You can share your slides, share screen.
Yeah, please. I'll do that. Okay, so the topic was nivolumab in just 1 second. Let me nivolumab in non-small cell lung cancer. Are my slides visible?
Yes, sir. Yes, they are visible. Sir. Please carry on.
And very interesting because nivolumab seems to be one of the drugs which goes in and out of vogue. And it's been out of vogue for a while after making a big bang almost 5 years ago and seems to be coming back. Just since we're speaking on nivolumab and non-small cell lung cancer, there are 3 key indications in non-small cell at the moment. In first line, PD-L1 expressing patients with ipilimumab, and this is the checkmate 227 which we'll discuss briefly. In the second line, without PD-L1 expression to anybody, and this is till disease progression, and either in first line or second line, and this is very interesting, in combination with ipilimumab and nivolumab with 2 cycles of chemotherapy, and we'll just go through that very briefly and start with that. But clearly, the first and the most important message is, as things stand today, there is no indication on nivolumab as a single agent in first-line metastatic non-small cell lung cancer. And this was post the failure of Checkmate 026 to show benefit, either PFS, OSS, or response in PD-L1 more than 1%. And these are very clear graphs. This did not show benefit. To be fair, it included me. We were a bit shocked because as a group, we expected this benefit to be seen, but that was data. But that opened up question of nivolumab as a IO or immuno-IO combination with chemotherapy in the first line setting. ASCO 2020, we saw the 3-year update of Checkmate 227 part 1. For anybody who knows this trial, it is one of the most complicated trials, which is divided into part 1, part 2, more than 1% PD-L1, less than 1% PD-L1, segregation based on PD-L1 as well as TMB. And I think it's a very difficult to interpret trial. Having said that, what it already had shown is that previously nivo-ipi combination had significantly prolonged OS versus chemotherapy in more than 1%. In this data, we saw both 1% and less than 1% PD-L1 expression, and we saw the 3-year updated study. Very important landmark. As I said, this was a very complicated trial where the PFS was seen with the TMB versus OS was seen with the PD-L1. The group 1 was more than 1%, group part 1B was less than 1%, and they had a 3-arm comparison of nivo versus chemo versus nivo and ipi. So complicated trial. Nevertheless, a lot of information came out, especially this year, where we saw that the group was fairly well balanced, mainly non-squamous, as would be our current population, with a PD-L1 expression of almost 30-70 of less than 1 and more than 1. And when we further divide, there was equal numbers in more than 50, less than 50. So this will be a very true representation of our patient population as we see in our group. And it showed that in the group of more than 1%, there was a clear separation of curve of 3 years at 33 versus 22%, with a median OS of 17.1 in the combination versus 14.9 in the chemotherapy alone arm, and a confidence interval which did not cross 1 in the nivo arm, which, as we previously agreed, was not shown because the confidence interval crossed in the nivo alone arm. What was interesting and very important to note is that the gap got wider when we gave nivo-ipi versus chemotherapy in the PDL less than 1% population. So clearly, while nivo may not be the right choice with the chemotherapy versus chemo alone, the nivo-ipi, this is the non-chemotherapy arm, may be as compared to chemo alone. They did this then landmark analysis based on 6-month response rates, and they concluded that first-line nivo-ipi provides a durable clinical benefit in both groups, OS of more than 1, less than 1. People who were responding at 6 months actually gained a huge benefit, and we'll see that in the 9LA study as well. So this is the second first line study. I think this is very critical, and I'll come to why I say that. But the nivo-ipi plus 2 cycles of chemotherapy versus chemo alone. So they picked up from 2 to 7, where nivo-ipi showed benefit from chemo alone. And they said, what if we used to nivo-ipi with chemo rather than nivo-chemo, and made the 9LA? And essentially, I think we've discussed it. Essentially, we had a fairly bad population. 1/5 were CNS metastasis and another 1/5 were liver metastasis. So we cannot say this is for only good group of patients. And do look at a fair amount of smokers in this and fair amount of non-squamous as well. The PD-L1 expression was significant, 60% more than 1, 40 less than 1. As I said, this is classical of what we're seeing, with about 3/4, 1/4 divide into 1 to 49 versus 50%. And the interim analysis, we saw that again, there was a significant difference in the curve. And please note that the curve continues to straighten out and separate when you look at nivo-ipi with chemo versus chemotherapy alone combination, hazard ratio 0.66, and the confidence interval was less than 0.8. Very interestingly, subgroup analysis showed almost everybody benefited, but I really want to show that the entire PD-L1 population benefited, as did the squam and the non-squam. Now, the patient with no liver metastasis did better. Squam, the ones with liver, we did not know so much. I guess we've crossed confidence interval and we need more numbers there. Histology-wise, squam versus non-squam benefit, and if you notice, the benefit in squam is higher. Not surprising, because this is the smokers group, and so we see more. When we segregate that by more than 1, less than 1, and even further, 1 to 49/50, we see benefit across almost all groups. And please notice the straightening of line towards the end in all nivo-ipi chemotherapy curves. The toxicity was certainly more, and that would be expected, but I guess it was acceptable considering that a population of patients were tolerating at long term as well. In summary, it said that nivo-ipi chemo should be considered as first line option for patients with advanced non-small cell lung cancer. When you look at the second line option, I think there's a fair amount of data for both from squam and adeno, which is the checkmate 017 and 057 population, comparing it to docetaxel. But I'll just present the 2019 World Cancer Lung Cancer summary, because I think that speaks volumes. This is the 9-year checkmate 003 early phase trial, where they've still shown 15% people beyond 5 years survival. This is not known in the non-immunotherapy era at all. So I think it's very important to see that the two studies, the squam 017 and the non-squam 057, randomized chemo and immunotherapy. And at 5 years, as I said, we are seeing almost 14 versus 2.6%. This 2.6% is not unknown to us. I think there are hardly any 5-year survivors. But if 14% of them can survive on nivo alone in second line, I think it does beg the question, what would happen if you get it right in the first line? And should all patients blindly be put on nivolumab, irrespective of PD-L1 expression, in second line, and this is less than 1% expression at 5 years, still sitting at 8 versus 2. And this is the pooled analysis of PFS and disease control it. And if you look at the DOR, you see 32% patients who responded continue to respond. And so it's very important how the PFS benefit is smaller, but the people who respond continue to respond. And this is another way of showing that in the landmark analysis of PFS at 2, 3, and 4, which shows for patients, 82% of patients who actually did not progress at 2 years continue to do well. Patients who did not progress at 4 years, almost all of them were alive at 5 years. This is huge, although it's 15%. This is huge because this tells us that this is a treatment which even in second line patients can have patients who both respond at 6 months, at 1 year, at 2 years, and many of these may continue to survive the 5-year point. I think one very important point should be how do you compare Nivo to others in the first line setting? And I think this is interesting because we have all agreed, accepted, and not more or less debating if we had to use single agent immunotherapy, it would be pembrolizumab in PDL1 more than 50%. However, the question remains, is PDL1 not more than 50%? And you see this comparative data is more or less similar, except 2 points to make. When you look TMB in 227, you see Nivo-Ipi does a phenomenally good job. And again, when you look at the non-squamous histology, you look at that Pembro, Pem Platinum does a very good job. So the question that starts emerging is there a difference between squam and non-squam? Is there a difference between PDL1 and TMB? Very quickly, second line advanced setting without actionable mutation, very good commentary from Alessandro Morabito. Please do read this. And when you look at the nivolumab, we clearly see that both in squam and adenocarcinoma, there's a clear difference in the median overall survival as compared to other agents. But I think in conclusion, with a spelling mistake in my spelling of conclusion, I do feel nivolumab still remains in the race for first line therapy, certainly not a single agent, and I would not put it down as for patient more than 50%. But here's the question. For patients who are not fit for chemotherapy, are they fit enough for ipilimumab? And if they are, should we consider this as a non-chemotherapy option? I think for most of us who have less experience on ipilimumab at the moment, I think we struggle to think about it. But so far, all the patients who I have given AP2, thankfully, have actually not had a very bad toxicity, less than I expected. So I am keen on trying this, but the question is where? The first question I have is, should we consider this in patients with high volume, especially the 9LA, where we can use chemotherapy, Nivo and Ipi, and we know many of these patients, even at more than 50%, we be reluctant to give immunotherapy alone. So I'm questioning to the bigger audience here and to myself that when I next get a patient who's not got targets, who's squam and has high volume disease, if I've considered fit enough, should I be considering a chemo IO combination? I think that's a question that remains to be answered to my mind. Again, I think I question in PDL1 alone should be used to predict response. And I'm questioning this more in squamous, and I'm questioning this more in smokers, because I do believe that there is some ability of TMB, at least to add to the PDL1 in the nivolumab group. TMB for other immunotherapies, I think I would stay away. But if we are using nivolumab, if we have a squam, if we have a smoker, and especially if high volume, I think I would look at that carefully. The second line remains the standard of care, irrespective of PDL1 positivity. And I think we've all seen responses with ramucirumab data being quite clear. I think there is question of should we use in all comers. Do remember that the 5-year survival was 15% in all comers versus 8% in patients who were PDL1 negative. So I think it remains a very important question in my mind. But the bigger question is high volume disease using chemo immuno combination and the role of TMB. With that, saving your conferences a minute and a half, I conclude. Thank you.
18 kilometers.
Dr. Sudeep is still on mute, sir.
Thank you, Dr. Dinesh, for being on time. Now, floor is open for question and answer. We'll allow 1 or 2 questions because we have 1 minute left. If there's no questions, then I would like to invite Dr. Shyam Agarwal. Dr. Shyam Agarwal, you will be talking about the role of durvalumab in stage 3 non-small cell lung cancer. Dr. Shyam Agarwal, please.
So thank you, Sudeep, and thank you, Dr. Ranga Rao. Am I audible, please?
Yes, yes.
Yes, sir, you're audible.
Thank you. So thank you very much for inviting. So can the organizers share the slides? So I'm going to cover the subject of stage 3 inoperable non-small cell lung cancer. So can I have the slides, please?
Yes, sir, we are doing, sir. Please share the slide.
So I think we are aware of the role of immunotherapy. A lot of times those slides have been shown relating to durvalumab and Pacific trial. So I have no choice but to, repeat a lot of those slides. But
so you are on now.
So I think maybe we'll try and focus on some aspects relating to the inclusion criteria or patients who are eligible for concurrent chemoradiation, and of course that is usually supposedly to be followed by durvalumab because that has become the standard of care.
Hello,
So
good evening, sir. Have you shared the slides on email ID?
Yes, I sent you the evening itself the slides.
Sir, we haven't received yet.
So then I don't know, I can't share the slides right now. So I can actually, speak on the subject for about 10-15 minutes.
Sir, have you shared on the conference email ID? I will recheck.
If that is okay with you. Yeah, on the one which I had sent.
Okay, sir. So give us a minute.
Sir, please start, sir. We'll try to find your slides, sir, in between, sir.
Right. So I think I'll make a speech on the subject.
Yes.
So I think I think we all understand that the incidence of stage 3 non-small cell lung cancer is to the tune of 30%, or even certain studies say 40-50%. So which is a fairly huge number of patients when we come to non-small cell lung cancers. So the question is, who are the patients who should be subjected to this concurrent chemoradiation? So when it comes to selection, I think that is the key there. So I think when you go into the staging, so it is the nodal staging which is extremely critical, because patients who have ipsilateral mediastinal lymph nodes or ipsilateral paratracheal lymph nodes or central lymph nodes, so that is where the debate begins. So whether this patient should be taken up for surgery or should this patient is not eligible for surgery. So there's a lot of expertise required on the part of thoracic surgeon, and a multimodality approach is required where you need to select out these patients who are not suitable for surgery, because I think we understand that surgery would be the mainstay of treatment for these patients if the patient is resectable. So if somebody has a bulky N2 means mediastinal node. So if somebody looks like having a fixed N2, or a patient is having multi-station N2, so these are 3 points to my mind which will tilt the balance in the favor of concurrent chemoradiation. And in the new AJCC addition of staging, the supraclavicular lymph node or the the skeletal lymph nodes I mean, there is a new entity for the N3. And if somebody has N3, that automatically is going to, rule out a patient for surgery. And yeah, okay, so you have the slides. Can we, go to the 5th or 6th slide? Go ahead, please. Next slide. Next slide. Yeah, so this is what I was talking about, that, if somebody has, N3, which is supraclavicular or skeletal lymph nodes, well, these patients are again not suitable for surgery at all. And then, of course, if patient has contralateral hilar or mediastinal lymph nodes, so they're all candidates for concurrent chemoradiation and therefore not to be subjected to surgery. So I think this is the point I was trying to make, that, selection of patients for concurrent chemoradiation is extremely critical. So if somebody has, large lymph nodes in the mediastinum, patient has bulky disease, or patient has multi-station disease or supraclavicular nodes, so they should be straight away taken up for unresectable NSCLC. Can we have the next slide? Okay, so let's go ahead for the next slide. Okay. So I think this, as I said, requires a multi-modality approach to basically choose your patients. Next. Can I have the next slide? Okay, so I think the bottom line is clear, that if somebody has unresectable N2, those are automatically patients for concurrent chemoradiation. If somebody has a potentially resectable N2, maybe smaller nodes, then there the debate begins. Should we give them, neoadjuvant chemotherapy followed by surgery, or should they be taken up for concurrent chemoradiation? And that's where the multidisciplinary team comes in. Next slide, please. Okay, so this is, slides which show that concurrent chemoradiation is superior to radiation alone, or to superior to sequential chemotherapy followed by radiation. So this is the data to support the use of concurrent chemoradiation. Next, please. So, the problem with the concurrent chemoradiation is, if you look at the last two columns, the median progression-free survival is hardly, 9 to 10 or 11 months. So it's very dismal. And, the 3-year survival is to the tune of 15%. So it's a very, very bad disease when you treat patients with concurrent chemoradiation. Next, please. So, now the issue is on several chemotherapy drugs which are available. So if you use, paclitaxel and carboplatinum, so elderly patients have a high risk of developing pneumonitis. However, cisplatinum and etoposide is considered to be safer. This is from the STRIPE meta-analysis. Next, please. Okay, so I think we'll come to this subject when we are using durvalumab, because the issue of pneumonitis is there. Next, please. So, the outcomes from consolidation trials in locally advanced unresectable non-small cell lung cancer, where they've used drugs like docetaxel or a combination of platinum or docetaxel or pemetrexed, etc. I mean, you don't see much improvement in the overall survival as you see the last column. The only column which benefits is EGFR mutated when you use gefitinib. Next, please. So, in stage 3 unresectable, you don't have much role for consolidation. Even if you add more radiation, there is more toxicity. And the only, drug, as I said, which benefits perhaps is gefitinib. Next, please. So there's a lot of room or, for improvement, and it's a huge, huge unmet need. Next, please. Next slide. So this is what I said, that, you go for the next immunotherapy options. I'll skip these slides in the interest of time. Next, please. Okay, next, please. So that is where, durvalumab actually comes in, the role of PD-L1 inhibitors following chemoradiation. There is a scientific rationale where you see more of increased antigen release from dying tumor cells. There is upregulation of PD-L1 and immunomodulatory changes in the tumor microenvironment following, chemoradiation. So, there is a significant role for these, proposed role, at least scientifically or academically. Next. And then, when you're using drugs like durvalumab, as we all know, the axis between PD-1 and the PD-L1 is broken, and that leads to the activation of T cells. And therefore, it will lead to a much more tumor cell kill. And that is where the role of durvalumab is. Next, please. So I think the Pacific study, which you all know, I think I'll just rush through these slides. The important issue is that these patients were given, or at least therapy before putting them on chemo radiation. And the patients should not be progressing. The estimated life expectancy was cut off inclusion in the administration. The primary endpoint was PF. And of course, the ORR and the DOR and the other. Next, please. The dose of durvalumab every 12 months. Next. So the interesting part is that the projected based on the previous studies, the progression-free survival was 5 to 7 months, because after 6 weeks, the measurement of the PFS began. Next, please. As opposed to the other consolidation studies, and it's very clear here from this particular graph here that nearly 50% patients were progression-free at 18 months. I told you at 3 years. The otherwise the survival was 50%. So you see the difference between the something like 50% as compared to 26.7 months. Next, please. So these are several subgroups in the forest plot, and the patients who had PD-L1 more than 25% derived the maximum benefit. But as you see, most of the patients are benefiting irrespective of the 3A or 3B or squamous or non-squamous, or whether they had CR or PR before the start of durvalumab. Next. I think these slides have been shown a number of times, and the overall survival at 3 years was 57% in favor of durvalumab. Next, please. The overall response rate was 29% approximately, as compared to 16%, which was statistically significant. Next. So this is the time to death or distant metastasis. Again, durvalumab showing you, 23 months versus 14.6 months. Next. So I think the safety summary is fairly, as you know, there was some degree of immune-mediated side effects, but grade 3-4 were hardly 3 to 4%, and discontinuation was in 15%. Next, please. So I think we are all aware. I was mentioning about pneumonitis. So grade 3-4 was 1.3%, but fatigue and other side effects, as you see, were much lower. Next, please. Okay, so pneumonitis or radiation pneumonitis was seen, in nearly 33%, but leading to discontinuation was 6.3%, and in the placebo was 4.3%. Next. So I think there was an exploratory analysis. Impact of pneumonitis on efficacy was assessed via the Cox hazard model. Next. And the pneumonitis time endpoint covariate was not significant. P-value was, not significant in all the models. So I think the pneumonitis was not significant here. Next, please. So I think this is again, regardless of, the pneumonitis, the patients did show benefit. Next, please. So I think the important point is usually it is begun in less than 42 days, but it can be started after 42 days in the real world scenario, because the French study did show the benefit there as well. Next, please. So what about the other drug, which is pembrolizumab? So which is, used in patients with stage 3 non-small cell lung cancer who are not found to be suitable for surgery or concurrent chemoradiation. And the next slide shows you the demographics. Next, please. So nearly 12% patients. Next slide, please. So nearly 12% patients out of 1,275 patients were included in this study. Next, please. Yeah, so I think, can we go to the next slide? I think, and these patients had to have a TPS of more than 1%. And this is what I was saying, that nearly 12% patients had locally advanced stage 3 NSCLC, and Pembro versus chemotherapy was compared, and the inclusion criteria was TPS more than 1%. And now go to the next slide. And if you look at the hazard ratio in this locally advanced for various subgroups, if patient had PDL1 more than 50%, the hazard ratio is 0.28, more than 20%, 0.58, and more than 1% is 0.74. So this formed the basis of, administration for NSCLC, whether patients who are not suitable for concurrent chemoradiation or for surgery, they could be considered for such a drug. Next, please. So I think the ongoing trials for consolidation in stage 3 NSCLC are shown in the next slide. Next, please. So this is the Pacific-2 study where they are trying to use durvalumab upfront, followed by durvalumab along with the concurrent chemoradiation. And I think PFS is the primary endpoint. So the results of this study are awaited at this point in time. Next, please. So these are other several trials where people are trying to combine durvalumab and other immune oncology drugs like nivolumab, etc. So I think the trials are awaited. And let's go to the last slide. So I think based on the data which is available on the Pacific study, so durvalumab followed by concurrent chemoradiation is the standard of care at this point in time. And you see the significant PFS and OS improvement at 3 years. And I think in the French EAP, as I said, almost 40% of the patients were started on durvalumab beyond 42 days, and you had similar results as the Pacific. So low-grade pneumonitis is not a deterrent for using durvalumab as per the real world data as well. So I think durvalumab remains the treatment for all group of patients with stage 3 who are subjected to concurrent chemoradiation if they have not shown progression on concurrent chemoradiation. So with this, I'll close here and thank the organizers for this opportunity. Thank you very much.
Thank you, Dr. Shyam Agrawal, for making the things very easy and talking about the role of consolidation therapy, immunotherapy in stage 3 lung cancer after CTRT, especially about durvalumab. So floor is open for the questions. I think there is one question from the chat box. The question is regarding the optimal time to start this durvalumab after CTRT. I think you have talked about 42 days. So what is the optimal time?
So, as I said, it should be within the first 42 days as per the trial, which was, in the inclusion criteria. But I think because of the radiation, some patients do tend to develop, some pneumonitis, which could be responsible for delay. But I think you should not be going beyond 50 or at the most 60 days. But ideally, we like to start within, 6 weeks, preferably in 4 weeks' time.
Thank you, Dr. Shyam Agrawal. Now, Dr. Subhash Ranjan, are you there to take over?
Sir, there's another question, sir, by Dr. Deepak Singla. What should be the duration of the durvalumab?
So as I said, it is given 10 milligram per kilogram every 2 weeks for a period of 12 months. So for 1 year. And okay, we've had, 2 patients whom we treated and both are doing extremely well.
Okay, sir. Thank you, sir. Thank you very much, sir.
Yes. Thank you.
Thank you, Dr. Thank
you. Dr. Subhash Ranjan, are you there?
Sir, Dr. Subhash Ranjan couldn't join because of some technical glitch. Dr. Manish Singhal is also in an emergency. So we'll shift to the next topic by Dr. Mridul. Then come back to Dr. Manish. So, Dr. Mridul, Dr.
Yeah. So I would like to...
Dr. Sudeep, you can introduce Dr. Mridul then.
Okay, now we have a third speaker, Dr. Mridula Malhotra. He'll be talking about the role of pembrolizumab as a first-line treatment in metastatic non-small cell lung cancer. Dr. Mridula, please.
Thank you, sir. Can I share my screen? Yeah.
Sure, sir.
So the slides are visible?
Yes, sir. Please
Yeah,
continue.
Thank you. So after discussing the two immuno-oncological drugs by the avid speakers, I'm taking up the third drug, and that is the pembrolizumab in first line metastatic non-small cell lung cancer. And actually, Shyam Agarwal sir has already spoken about this in the first line setting in the TPS score of more than 1%. I'll be restricting my talk to mainly TPS score of more than 50%. So this is a sponsored presentation, and this will be the flow of my presentation. So we all know chemotherapy has been a traditional way of treating, and it acts on various phases of cell cycle. It is non-specific in action. And then came the era of targeted therapy, where the specific targets that are the driver in the cancer cell growth and proliferation are targeted. And by exploiting the multiple modalities, like one of them is evading immune destruction by the cancer cells, if we are able to inhibit that, there comes the role of immunotherapy. And while we combine all of them, then it can achieve even better results. So these are the mainly milestones in the treatment of non-small cell lung cancer. One, the role of chemotherapy was established in 1948 when nitrogen mustard was shown to improve symptoms and performance status in advanced bronchogenic carcinoma. Then came the first generation of chemotherapy, but the overall survival was in the same range of 4 to 5 months. And with the approval of platinums, it just extended to few more months. And in the present era, when we use pemetrexed and bevacizumab, then in fact, the OS has not crossed 8 months, which raises a question that mainly the plateau with the efficacy of chemotherapy has been reached. And of course, I've spoken about the targeted therapy, so I'll skip this slide. And these are the targeted. EGFR is the most common targetable mutation in the lung cancer, and development of EGFR inhibitor started in 1997. And then EGFR sensitizing mutations were noticed in 2004. And this was followed by the approval of geftinib, erlotinib, and afatinib, doing better than the conventional chemotherapy and becoming the preferred first-line therapies in these patients. And then various other next generation TKIs, osimertinib and dacomitinib, are now gradually taking the first place in the treatment of first-line treatment of EGFR mutant patients. Next most common is the ALK mutation, which is next most common targetable mutation in lung cancer. And crizotinib has been the first generation ALK inhibitor approved in 2011. This was followed by next generation drugs like ceritinib with better CNS penetration, and then approval of alectinib in the first line with LX and JLX study. And then besides this, there have been approval of brigatinib, which was initially on crizotinib progressed patients and later as first line ALTA trial. And now lorlatinib has come, which has excellent brain penetration and is approved post 2 lines of ALK targeted therapy. And these are various other targeted mutations and their respective target inhibitors, but the incidence of all of them is very less. So we all know the burden of non-small cell lung cancer worldwide. It ranks as the leading cause of cancer death and mortality. And because mainly of the non-targetable options available, the chemotherapy was the only option in such patients. But now we have PD-L1 as an expression of biomarker that is important in forming the first-line treatment of patients with metastatic non-small cell lung cancer, both squamous and non-squamous. So this is again representing the disease burden in India, with lung cancer as the fourth most common in terms of incidence. And it is the third highest in mortality in India. So coming on to the mechanism of action, it has been discussed by previous speakers, like the PDL1 is a key immune checkpoint pathway involved in the evading the immune response by cancer cells by inhibiting the T cell mediated immunity. So basically the tumor cells, they downregulate the T cell activity by exploiting the PDL1 checkpoint pathway, and both PDL1 and PDL2, they engage the PDL1 receptor and inactivate them, which allows the tumor to invade the immune response. So pembrolizumab, it is a high affinity antibody which exerts dual ligand blockade against both PDL1 and PDL2. And this diagram represents how the activation, the deactivation of cytotoxic T cells is inhibited by pembrolizumab, which is a PD1 antibody which binds with the cytotoxic T cell and inhibits the interaction with the PDL1 and PDL2. So pembrolizumab is approved indication in a non-small cell lung cancer with a TPS score of more than 50% with no EGFR ALK mutations. It is used as a monotherapy in this indication, and basically the loading doses 200 mg to be given over 30 minutes, and the frequency is every 3 weeks. So let us come on to the study which led to its approval. Keynote 024, we know it is a comparison of pembrolizumab versus chemotherapy in first-line non-small cell metastatic lung cancer patients with a tumor proportion score of more than equal to 50%. And the study met its primary endpoint, and the trial was stopped ahead of this thing. So this is the study schema, where untreated non-small cell lung cancer stage 4 patients with no EGFR ALK mutations, untreated CNS metastasis, and in the absence of autoimmune diseases were randomized to 1:1, and crossover was permitted to in the either arms. And the primary endpoint was a PFS, and secondary endpoint was overall survival, overall response rate, and safety. And this is the disposition 1:1 randomization, and approximately 98 patients out of 150 patients were crossed over to the pembrolizumab arm, which leads to the crossover rate of around 64.9%. And around 65 patients from the pembrolizumab were crossed over to the subsequent anti-cancer therapy, which leads to crossover of 42.2%. The updated analysis had a follow-up of approximately 44 months. Baseline characteristics of both subgroups were comparable, except pembrolizumab had 11.7% of brain metastasis versus 6.6% in the chemotherapy arm. And the chemotherapy arm had a higher number of liver metastasis, 23.8% versus 13% in the pembrolizumab arm. Retrospectively, looking at 38 patients who completed pembrolizumab complete 35 cycles, that is 2 years of therapy. There were 38 patients. They were mainly non-smokers. 9 had the brain metastasis, and none of them had the liver metastasis at baseline. So the primary endpoint was met, where the significant PFS benefit was seen with pembrolizumab arm with a hazard ratio of 0.5, showing a 50% benefit in the reduction in the risk of progression and death in the pembrolizumab arm, and the separation of curves started as early by 2 months, and that separation was maintained throughout. Then there's a concept of PFS2, which is also approved by the European Medicine Agency, that it is a time from randomization to objective tumor progression in the next line of treatment or death from any cause, whichever occurs first. And PFS2 is used in cases where OS cannot be measured because of the clinical or financial reasons, and to assess the clinical benefit of agents that do not induce responses, to assess the maintenance therapy, to assess the impact of crossover on overall survival assessment, and to see whether the therapy positively or negatively affects the efficacy in the next line of therapy. So even PFS2 was better in the pembrolizumab arm, where median PFS2 was 18 months versus 8.4 months with a hazard ratio of 0.54. And the 12 months PFS2 was 59% versus 38%, and 18 months PFS was 51% versus 24%. So even the crossed over patients who crossed over from chemotherapy arm to the pembrolizumab arm with a high tumor proportion score, they in fact did much better. So this is the overall survival, again, which is showing a significant benefit for pembrolizumab arm versus chemotherapy. And in this, it was basically a crossover adjusted overall survival, where the overall survival for pembrolizumab arm was 30 months versus 8.7 months, while if the crossover was not adjusted, then the overall survival was 14.2 months for the chemotherapy arm. And there was a significant difference in both the arms, clearly suggesting pembrolizumab had an overall survival also. And this is the 3-year overall survival data showing benefit of pembrolizumab, 35% benefit in the reduction in the risk of death. Response rates in the pembrolizumab arm were also better to the tune of 45%, while chemotherapy responses were 29%, with a clear difference of 15%. The median time to response were similar between the two groups, but it happened at two months, and after that there was clear-cut separation of curves. Then the patients who crossing over to the on-study pembrolizumab arm, their baseline characteristics were also similar to those with the overall population. And the median duration of response was not reached in these crossed over patients. Overall response rates were 20%, and the stable disease was seen in 23% of the patient. So overall clinical benefit was seen in 43% of the patients. And so ultimately, even the patients who were crossed over, approximately 43% of the patients continued to maintain the clinical benefit. So this is the response after completion of 2 years of pembrolizumab. 38 patients could complete 2 years of pembrolizumab. Here, the dark green bars indicate the treatment duration, and the light green bars indicate the first course of follow-up duration, where follow-up was defined as a time to progression or last non-progression assessment by investigator. So then there were patients who also received a second course of pembrolizumab after completing the first course of 35 cycles. So second course here is demonstrated with the star, and these patients also they had good sustained responses in the second course of treatment. So among patients that had completed 2 years of treatment, 33 patients had treatment-related adverse effects out of 38 patients, but serious effects were seen in only 5 patients, and immune-mediated effects were seen in 1/3 of the patients, and out of these, only 2 patients have had severe grade 3 to grade 4 adverse drug reactions. So this is the slide to show the re-challenged second course, where 10 patients were re-challenged with pembrolizumab, and 7 out of 10 had this partial response or stable disease, and the 8 patients remained alive, and 5 patients were continued on the pembrolizumab at data cutoff. It just shows the feasibility of second course of treatment. Treatment-related adverse effects was 77% in the pembrolizumab arm versus 90% in the chemotherapy arm, and the incidences of serious treatment-related effects were 22.7 and 20%, and a treatment discontinuation was there as a result of treatment-related effects was 13% versus 10%. So the treatment discontinuation was also similar, and there were mainly 5 treatment-related fatal adverse effects, with 2 patients in pembrolizumab arm and 3 patients in the chemotherapy arm. And immune-mediated reactions were more in the pembrolizumab arm to the tune of 34% versus 13% in the chemotherapy arm. Those who had completed 2 years of therapy with treatment-related effects, around 87% of the patients had the treatment-related effects.
Dr. Mridul, can you wrap up? Because I think I'm afraid time is limited.
Okay. So basically, the main side effects, diarrhea, fatigue, were mainly in pembrolizumab. Anemia, nausea were there mainly in the chemotherapy arm, and they almost affected many parts of the this thing. But the main side effects would be a pneumonitis, infusion reaction, colitis, hepatitis, and skin reaction. Health-related quality of diet data was also better with the pembrolizumab arm, and it was not reached versus it was 5 months with the chemotherapy arm. And PD-L1, it is important to basically check for the PD-L1 tumor proportion score, which is a percentage of the patients staining tumors staining PD-L1 versus the total tumor. So we in this study around 1,653 patients were tested and 30% had tested positive. So it is important to test PD-L1 at baseline, screen the patients who are a candidate for single agent pembrolizumab. So to conclude, it is a only anti-PD-1 approved antibody for the first line treatment, and it has shown an overall survival benefit to the tune of 26 months versus although its comparator arm also showed had a higher overall survival of 14 months as compared to the previous other trials, and the progression-free survival was also higher. Immune-mediated effects were manageable and they were not that serious. Then it is less toxic than the chemotherapy, and 2 years of therapy is again feasible, and even second course can be tried in patients who are affordable. And we should always test the patients at the baseline for PD-L1 expression tumor proportions. Thank you, sir.
Thank you, Dr. Midul, for your wonderful talk. So I would just like to invite our last speaker, Dr. Manish Singhal. Dr. Manish Singhal, are you there? Dr. Manish Singhal will be talking about paradigm shift.
Yes, he's there.
Yeah, so you'll be talking about paradigm shift in lung cancer, treatment with immunotherapy. Dr. Manish, please.
Thank you very much. Please allow me to share my screen.
Yes, please do it, sir.
Is my screen visible? No.
No, sir.
Yeah. Yes, sir, you're visible now.
Why am I not able to see? 1 second, sorry. But I'm not able to see my screen. I don't know what is happening. 1 second.
We can see.
I'm not able to see my screen. Where has it gone? Oh.
So you can retry sharing your screen again.
Okay.
Yes. Is it visible now to you, sir? Dr. Manish?
Yeah, it is still not visible to me.
But we can see it now, sir.
Okay. Wait. I don't know.
We have the slides, we can try sharing.
Okay. Let me just present like this only then.
So do you want, we can preview your slides ourselves and you can just speak looking at the slides.
But I've never sent the slides to you. Which slides do you have?
Achha. You don't have slides?
No, I didn't send the slides to you. So are my slides moving?
Yeah, no, they are not. Only the first slide is there. Yes, now they are moving, yes.
Okay, let me, without wasting time, let me just start my presentation. So I'll have to keep it like this because I don't know, it's not really moving. So I'll keep it not on the full screen mode, but like this only.
Fine, sir.
So
Fine.
coming to the paradigm shift of in non-small cell lung cancer with immunotherapy, of course, we all have witnessed that very much. And of course, not only this, immunotherapy has been tried in very early stage lung cancers, wherein pathological CRs or major pathological remissions have been one of the endpoints of these studies, although immunotherapy has not yet been approved for localized resectable lung cancers. But there has been two landmark papers, one with atezolizumab with chemotherapy and one with nivolumab alone in the neoadjuvant setting in surgery, where major pathological responses have been registered to the tune. One of the hallmarks of bringing to early stage lung cancers. But so far, it has been approved in locally advanced and advanced lung cancers. So looking at locally advanced lung cancers, we know that stage 3 unresectable lung cancers have been mostly dealt with chemoradiation, and definitive CTRT has been the standard of care. And usually, because of availability of no other agents, sequential, sometimes chemotherapy, adjuvant chemotherapies were advised in these particular patients, and but there was hardly any change in survivability by giving additional chemotherapy after the CTRT. Not only this, many attempts were there about increasing the dose of radiation or adding different agents such as cetuximab in the RTOG 517 studies, 617, studies, but no major change happened. And that was a time when immunotherapy was brought in. So we had durvalumab, which was the first FDA-approved therapy as a consolidation therapy in stage 3 unresectable lung cancer, and it is a PD-L1 inhibitor. And we have seen the results of the durvalumab, which was a 2:1 randomization to durvalumab after completion of CTRT within 42 days of the completion of chemoradiation, with PFS and overall survival as the co-primary endpoints and overall response rate as the secondary endpoint. We have almost 4 years of follow-up data, wherein 19% versus 35%, almost doubling of the number of patients who are alive, has been registered with a progression-free survival of 0.55, hazard ratio of 0.55. The PFS increased from 5.6 months to 17.2 months. So immunotherapy has really led to unprecedented outcomes. The overall survival at 4 years has been 49.6% versus 36.3%. And if you look at the median, it is around from 29 months to 47.5 months. So almost practically doubling of the median overall survival as well. Looking at various subset analysis, it is clear that it almost benefits everybody as far as the PFS is concerned. Whereas when we look at the OS, there may be some crossing of the unity line, the 95% confidence interval, but the point estimates are all in favor of durvalumab. There is some data to suggest that those who have less than 1% PD-L1 expression, one may not get the required benefit or the perceived benefit. So is true for EGFR mutated patients, and this has been a matter of debate in various academic forums. So as far as induction chemotherapy followed by CTRT is concerned, there were about 1/4 patients who received induction chemotherapy followed by CTRT, and even this population also benefited from the addition of durvalumab. Not only this, there was decrease in the brain metastasis. Perhaps this was explained by the greater increase in the systemic control of the disease. So even brain metastasis was reduced to half with the use of durvalumab. So immunotherapy is definitely in as far as locally advanced lung cancer is concerned. Now coming to advanced lung cancer with high PD-L1 expression. So I'll skip the case-based discussion. So we have almost positive first-line immunotherapy trials. These are namely the Keynote 24, the 42 and 189, IMpower 150, and the Keynote 407 and the Checkmate 227 study, which basically randomized patients based on TMB status. And all these studies have been more or less positive in terms of their progression-free survival and also in terms of overall survival in most of these studies. Diving deep into these studies, the Keynote 24 was a first-line pembrolizumab study, which was a phase 2 study which randomized patients who had a PD-L1 expression of more than 50% with no or untreated CNS metastasis CNS meds, and they were randomized to pembrolizumab or platinum-based doublet chemotherapy based on the choice of regime based on squamous versus non-squamous, with PFS as the primary endpoint. And the progression-free survival was improved from 6 months to 10.6 months, and this was statistically significant. So was the overall survival, which reached almost a hallmark of 30 months versus 14.2 months, which was almost doubling of the overall survival. And we can also appreciate that there is some flattening of the curve, although most of the censoring is happening at the end of the curve. The keynote 189 was a combination of immunochemotherapy. That is the combination which is used in clinical practice the most. And this was irrespective of the PD-L1 status, whether less than 1% or more than 1%. But the primary endpoint of this particular study was overall survival and progression-free survival. And patients who had high PD-L1 expression, they had unprecedented overall survival and PFS, which was reached in this particular study. The median overall survival was not reached, which was at around 18 months, in excess of 60%, which was around which was around 10 months in the placebo. So not only this, so if we talk of which is the optimal treatment for PD-L1 more than 50%, whether we go for pembrolizumab alone or we go for pembrolizumab plus chemotherapy. So the preferred agent is immunotherapy alone. But if one has a symptomatic high-risk patient, then perhaps a chemoimmunotherapy option is better. Also, if you look at the hazard ratio of pembrolizumab versus chemotherapy in the keynote 24, in PD-L1 expression of more than 50%, it is around 0.55, which is around 0.45, which is with pembrolizumab plus chemotherapy. So most would prefer pembrolizumab plus chemotherapy, as most patients come with quite voluminous disease. Coming to the optimal treatment of patients with non-squamous non-small cell lung cancer without PD-L1 expression, I'll skip the case-based discussion. And so we have, again, coming back to keynote 189 study, which had patients who had a PD-L1 expression of less than 50% also. But the median overall survival was improved irrespective of the PD-L1 expression, as is depicted in these very Kaplan-Meier curves. The PD-L1 expression of less than 1% also fared well, and the hazard ratio was impressive, almost reaching to 0.59 for PD-L1 expression of less than 1%, with pembrolizumab plus chemotherapy versus placebo and chemotherapy. For 1 to 49%, the hazard ratio was 0.55. And as I said earlier, the hazard ratio is 0.42 with more than 50%. If you look at the same hazard ratio for more than 50% with pembrolizumab alone versus chemotherapy alone, the hazard ratio is 0.56. So definitely pembro plus chemotherapy seems to do better as compared to pembrolizumab alone if you have a cross-trial comparison based on hazard ratios. IMpower 150 is another study which combines atezo plus bev with chemotherapy versus chemotherapy alone. Although the arm which had atezolizumab alone without bevacizumab didn't really fare well. So the question is of atezo bev plus paclitaxel type chemotherapy, and the study measures primary endpoint with PFS improving, with the hazard ratio reaching almost 0.59, which is what you reach in an unselected population with pembrolizumab. The overall survival is again 0.76, and it is again statistically significant. And this is particularly true for EGFR and ALK mutated population, and also those who had liver metastasis. So in this forest plot, I'm sorry the graphs is not coming up well, but because I've changed my desktop, but the EGFR and liver metastasis actually fared the best with the combination of atezo, paclitaxel and bev. So this has been an area of interest, that those patients who have had a EGFR, ALK or sensitizing mutations and have failed TKIs and do not have any subsequent TKIs to follow upon, this is one particular combination which can result into better overall survival. First line atezolizumab plus chemotherapy in stage 4 non-squamous non-small cell lung cancer. IMpower 130 is another study which randomized patients to different types of regimes. So there were two studies, 130 and 132. Again, atezolizumab plus chemotherapy resulted into some improvement in median progression-free survival, but the overall survival in most of these studies could not reach statistical significance. So atezo, if has to be used, it has to be used with bevacizumab. With no PD-L1 expression, if one would conclude, perhaps still the pembrolizumab plus chemotherapy is the preferred option, although one IM power 150 regime, which bevacizumab and atezo, may be a good treatment option, especially in patients who have received TKIs for mutated non-small cell lung cancer and do not have any targetable mutations when they progress. Coming to treatment of squamous non-small cell lung cancer with low PD-L1 expression, again, I'll skip these slides, but the study which randomized these patients is the Keynote 42, and they had patients randomized to pembrolizumab versus chemotherapy with a PD-L1 expression of anything which is more than 1% with PFS as a primary endpoint. It did show that those patients who had PD-L1 expression of more than 1% also benefited, but had lesser degree of benefit. But those who had PD-L1 expression of more than 50% actually had the most benefit. So the question is, should pembrolizumab monotherapy be extended to patients who have a PD-L1 expression of less than 50%, that is 1 to 49%? Well, it will not be correct to say that it has equivalent survival, although the curve seems to be very overlapping. But yes, if a patient is not a good candidate for chemotherapy or cannot tolerate chemotherapy, this is one option which can be rendered to these patients. But most of the benefit of this curve is coming from patients who have more than 50% expression of PD-L1. The 407 is the Keynote study which randomized patients to paclitaxel carboplatin or nab-paclitaxel carboplatin plus minus pembrolizumab in non-small cell lung cancer. And they randomized patients, all comers, be it PD-L1 expression of more than 1% or less than 1%. And in this particular study, the median overall survival was improved from 11.3 months to 15.9 months with a hazard ratio of 0.64. And almost all the subgroups benefited irrespective of the PD-L1 expression. And so was true for progression-free survival. So the various reactions and toxicities of immunotherapy are well known to all now, and I'll not really dwell on this. Another study which was based on atezolizumab in the same setting of squamous cell carcinoma also resulted in improvement in progression-free survival, but the OS was not very improved. So this did not really receive the due approval. So to conclude, options for patients who have squamous cell carcinoma, low tumor burden of PD-L1 expression, the preferred therapy is a combination of pembrolizumab plus paclitaxel and carboplatin, or a nab-paclitaxel carboplatin. Those who have PD-L1 expression of more than 1% but less than 50% and are not candidates for chemotherapy may receive pembrolizumab monotherapy as a treatment option. My final slide is this. So if somebody has a PD-L1 expression of more than 50%, be it squamous or non-squamous, pembrolizumab monotherapy or pembrolizumab plus chemotherapy, but most prefer pembrolizumab plus chemotherapy. Between 1 to 49%, again, it is mainly pembrolizumab plus chemotherapy or a pembrolizumab. The choice of chemotherapy can differ between squamous and non-squamous. For less than 1%, again, it is immunotherapy plus chemotherapy. So this has almost become a standard of care treatment. Atezo plus bevacizumab carboplatin only for non-squamous histologies. Particularly, this is being used after patients who have EGFR mutations, and when they relapse and do not have any other mutation to follow upon, such as T790M, to receive osimertinib, such patients may receive a combination like this. Where does TMB fit in? We don't really know, because the Checkmate 227 study was a very confusing study. And as a matter of fact, the TMB, which was one of the primary randomization criteria in that particular study, didn't really came out as a biomarker of response to Nivo-EP combination with or without chemotherapy. So we don't really know that the excitement on TMB has really fallen out as far as immunotherapy in lung cancer is concerned. So with that, I hand over the proceedings to the organizers.
Thank you, Dr. Manish, for talking comprehensive way regarding the status of immunotherapy in lung cancer.
Yeah, thank you, sir.
Yeah. So due to the limit of the time, so
Dr. Nitesh, I'll take over. Thank you, sir. Thank you very much. So, Dr. Nitesh, can you hear me, sir? Are you there, sir? Dr. Nitesh Rottagi, sir? No, I think he's left. Okay. So, Dr. G.K. Rath, sir? No, I think everybody. Okay, sir. Thank you very much. I, on behalf of organizers, thank all the speakers, panelists, and the chairpersons for their inputs. And thank you very much. I would request you all to be there tomorrow. Also, the session starts at 9 a.m. We'll have some interesting sessions on GI, GU, and hemat malignancies. And please be there. Thank you very much. Thanks, sir, Dr. Manish. Thank you, Dr. Rohtagi. Thank you very much. Thank you.